Yeah, you can record it. I don't think you have any objection here. Excellent, excellent. So this presentation is really the main focus of the whole training today. So I would like everyone to focus on what we are going to talk, because this is what we are going to discuss after that. So this is a picture from one of our simulation training courses that we have done in the past, and it is on a mannequin that we had at Wexham, which is a very high fidelity mannequin that can produce all the emergencies in obstetrics. So this is a talk from the EMBRAS and about the importance of teamwork and the training. And you can see that this is from the EMBRAS 2014, that the communication of junior staff is not informing. These are some of the issues that have been highlighted, from problems that led to harm to the patients, or in the cases that led to morbidity or mortality national-wide. So the communication and issue, situation awareness, team working, training, lack of training is one of the issues highlighted, and is also the other things that how they can state the problems. So we will come to more detail of all these things, and this is what we are going to look into when we are going to run our scenario. So look into the effective communication and senior support. So the finding of the report is that there is a widespread reluctance for trainee doctors not to contact consultant obstetrician and anaesthetists in a timely way. And I think for us, some of us who are doing some of the incidents or looking into these issues, you see that sometimes the delay will lead to harm to the patient. The second one is that because, whatever the trainee, their level of training is not as a consultant to make a decision. Sometimes it is more difficult. So there is an encouragement, and always we encourage that if you are having any question, please do contact your senior. The severity of the woman's condition was not always communicated to all members of the maternity teams. That's very important in NMDT work. And if you look at the labor ward in particular, if you are the anesthetist and you don't know that there's a woman in room 2 that had severe preeclampsia, nobody told you about it, or there is a woman in that other room and had difficult venous access or something like that, then when things become a little bit more patient critically ill, or there is an emergency need to go and help, you will be just faced with that problem, and knowing that problem in advance could help in making things better. The other issue is the appropriate level of critical care was not always provided, because as you are aware that sometimes patients, we can't look after them when they are in our maternity unit. We need to go and escalate the care to critical care. So that's an important thing, and it is highlighted, and that's why you can see that there's a lot of arrangement in all maternity units on where they are going to look after their patients when their condition get a little bit worse. And if you can see that at Frimley Park and Wexham Park, there are different arrangements. Frimley Park, any patient who need to go to critical care, they go to intensive care. At Wexham Park, we had an arrangement to keep the patient inside our maternity unit, and we create after the renovation of our unit 2 rooms, which we call it the enhanced recovery rooms. So we try to keep the majority of our patients who are level 1, level 2 in that area, just because we know that they need more intensive type of monitoring, and more they need more care than the others. This is the other things which came from the report: team working and managing postpartum hemorrhage. I think you are going to see that the scenario we are going to play after this will be about postpartum hemorrhage, because it's one of the commonest emergencies in our labor ward. And these are some of the themes that had been identified when they were looking at the cases in that report. So they identified that there is a lack of situation awareness when managing major hemorrhage. They also identified that there is delay in the team recognizing severity of the problem, failure to step back and take a broader view of the situation. I will come in the coming slides to just elaborate on these points. And also the other thing is that staff should tailor treatment according to diagnosis and continually reevaluate the situation rather than persisting with ineffective or inappropriate care. This is an essential point and it's very important. And you know that sometimes you go and see a patient and then the situation that you decide this patient is just now dripping, she just delivers, she is fine, situation is stable. These things will not stay like this. It might be after an hour or 2 hours because of this minor amount or small amount of bleeding, this patient will become unstable. So the situation will change. So that's mean that you have to change your way and you have to change how you are approaching this the treatment of this patient. So that's what we call that always you have to go backward and reevaluate the situation. And this is not only in obstetric, that's everywhere in anesthetics and emergencies. You have not always to be static and look at the situation as such. You have always to reevaluate the situation at its evolution. So as I said, this is the important things we are going to talk about today is about teamwork. And I think we all know by now, I think a majority had been into multiple lectures about the human factor, about teamwork and what that is what it is. And in simple term, definition of it is a combined effective action of a group working toward a common goal. And it requires individuals with different rules to communicate effectively and work together in a coordinated manner to achieve a successful outcome. This is typically what you need inside your labor ward, inside labor ward theater, when emergencies do happen, because you are here working with anesthetist, obstetrician, midwife, HCA, neonatal team coming through. So there are multiple individuals, multiple skills you have, and this work together when it is effective. It's very obvious. And you are going to see that in the scenario and that we are going to play shortly, that if it is effective, the outcome is completely different from a team where there is no cohesion of work, there is no leadership, there is no, the outcome will be completely different. So this is what this is about teamwork training. There's a lot of evidence that show from different studies, and you can see these studies there and the articles. We show that the teamwork and the training of the team is important, and that's why one of the things that it is important things that we are doing today. That if you took a team together, multiple members from different specialties together and train them, that will make more obvious more cohesion type of teamwork, and the outcome on the ground afterward will be different. And you know that now all the foundation here, they do this simulation and trainings. It's all because coming from this, that if you work in an environment, you train about what you are doing, training in a team, the outcome is better. And honestly, I have seen that in our teamwork, building up these scenarios for many years, that when you came to the labor ward, you know to whom you are talking with, because these people, they work together outside the labor ward in a training. When it comes to labor ward, the atmosphere for them is less challenging, especially for junior staff who they haven't had that many years of experience. So I'm going to go through some of the characteristic of the team. What is the most efficient team? And I think the majority of you will know these things from your work, that the team is the efficient team is that when they state the problem, declare the emergency earlier. That's an obvious things. When you know what you are talking about, what you need to do, then the outcome will be better because you start dealing with the problem earlier. The other one is about communication, about using the closed loop of communication. Is very important. If you talk to your colleague, okay, if I tell Zoe, can you please go and bring this, or Zoe, please can you do this? It's more obvious that Zoe will go and do that and come back to me, yes, I did it. Well, if I say, can somebody do that? This is a little bit an open loop of open question, is more open to who is going to do it. There is no direct communication. There is no direct responsibility to the person you are talking about. So that will make more efficient type of work. And also you have to hear from the person that they did understand what they are being told, and they will do it, and they come back to you and they say it is done. Treatment, and we all know that the quicker you do the management of the patient, the better the outcome. We all know that if you don't start giving the antibiotic early, if you don't give the adrenaline when the anaphylaxis, the outcome is not the same. So you have to start treating the patient. If you don't give oxygen, if you don't give these things, and the patient wasn't needing of them, the outcome is not good. This is the other thing, that there's no disturbance of the team. As you see that when I was doing the talk, somebody entered to the room and getting out. That's disturbance of the team. Imagine if you are doing a task and a lot of people going in and out, there is less concentration of the team on the task. So disturbance of the team is a factor of making increasing the chance of making error. Structured communication. I think we're all aware of the SPA style of communication, and we should use that in all our communication, because that, I'll come to an example just in the coming slides. It makes a huge difference of what you are going to talk about. The other thing is that these are the factor that that if you do the team work together, and key issues that you highlight while you are doing trainings, and they found that the issues that it's always important to be highlighted in this training is the good communication, the role of responsibility of each individual when they are doing the task, when they are working together, and they are always have to have the situation awareness, the pilot type of a view. Then you have to sit back and see what's going on, and then look at globally what's going on, and then you can advise on what you need to do and from looking at the situation. So these are important to make the whole activity and the whole outcome of the situation of what you are doing better. So this is what about the communication. So it should be effective, and we all know that the effective communication should be formulated in a clear message addressed to specific individual. As I said, when I said the name, you have to also make that contact with the person, so they know that they are the people. That's the person you are talking about. So it will be more direct communication. So you know to whom you are talking about, to whom you are talking with, and what they are talking about. Deliver the very clearly and concisely and emotion. So in situation of emergency, people that get distracted because of the mother is in danger or the baby is in danger, you have to be structured type of and very clear type of communication, and your volume, and you have to be sure that the person in front of you heard what you said and understand. That's why we say that you have to come back to me and tell me what I've told you. So this is the structured type of effective communication. And I think this is what I spoke about is about the SPA. So you have to mention the situation you are in, what is the background of the situation, what is your assessment of what's going on, and then what is your recommendation. So in the next slide, I will show you an example of what you are talking about. So this is a correct way of communicating this situation of a patient who is she is unwell. So you can just say that she's bleeding. Of course, this is Miss Mary Norton is having an antepartum hemorrhage. So now we tell what is it. We mention what is the situation. She is nulliparous and is 30 weeks pregnant. So this is the background of the patient. So she is in severe pain and in hypotensive and tachycardic, and her observation score 3 on the Muse chart. This is your assessment of the situation. So this is you are just what you find from the examination of the patient. I would like a senior obstetrician and senior midwife to review her immediately. This is your recommendation. So if you are on the phone of somebody tell you these few words of this patient, it's very clear for you that you have a patient who she's bleeding, and the person on the ground was worried about her because she is hemodynamically unstable. So it's very clear. So structured approach and structured telling of the story is very, very, very important. And we all know this story. Well, I don't know if we all know. It's very famous story of this pilot who had landed his aeroplane on the sea. And you know, when they revisited the tape when he was talking, they thought that he was just landing on a normal landing. It's just because he was calm, concise of what he is talking about, and he saved his life. So the I think we learned a lot from the pilots, and I think today, Zoe didn't mention, we have two colleague pilots who are teaching on the human factors, Dave and Alex. They are going to join us in the faculty when we are going to discuss the scenario, and we are very pleased to have them. They are always supporting us, and they will enlighten us on some of the issue in that scenario when we are going to talk about. So this is some of the examples that it's mentioned in the Embrace report 2016. This is a different report, and this is just about communication failure. And you can read about it. I don't want to read it all, but it just tell you that you don't when you are dealing with the patient, don't miss any information, because missing one information will be very detrimental on the outcome of the patient. So it's very important that you communicate very effectively. So we move from the team now to the component of the team, and I think we all know that the team has to have a leader, and the leader, who is the leader, what is the leader, what is the role of the leaders, and then you have a team. In every team, and we all know that we have to have a leader in a football or in any sport. You have the captain, who is the leader, and then you have the teammates who are playing, and each one of them has different rules. But if any one of them doesn't do their rules in a correct way, the team will not be effective. So leaders, and I think that this picture just explained to you that the number of the leaders we have, this is just an example, and the examples say that each of them has different role. He is a leader for different reason, and they have all of them different type or different style of leadership, but all of them is leading his team to a success, or her team to a success. So it is obvious that there's different leaders, different leadership style, and different objectives. So these are some of the example or some of the criteria of an ideal leader. So the leader's primary concern should be the success of the team, not the leader. And this is very obvious in sport. Being a leader is you want to score goals, you want to win the game, and you have to get all your colleagues and teammates to do that. So that's how you can be successful. You should be competent, and it is very obvious. I always mention team, and because I like football. So if you have a good captain, the good captain is the one who is the most competent. They don't want somebody who is a bad player. So always the one who is the most competent person, normally the one who is the heart of the team, will be the leader. Coordinate and motivate the team, sets clear goals, communicate clearly and simply, delegate tasks appropriately, respects expertise of team members, willing to listen and open to criticism. This is very important because if you go to our team, when you are working in the labor ward, you have different type of different people and different specialties and different skills, but each one of them had an important role to play. If any one of them didn't play the role, whether that's consultant or trainee or midwife or porter or SCA, every single one inside that room play a role, and it is the responsibility of the leader to use the skills of each one of them to deliver the care for the patient. Planning is very important, when you enter a situation, you have to have a plan in your head. You have to mention the plan to your colleagues, to the whole team, and then you follow the plan and you change the plan accordingly, according to changing the situation. Team players is very important. If you don't have teammates who playing the role, if you don't have team members in the team playing their rules correctly, you will not achieve. And you can see that he always, you see that they are the members of the team who are team players. They are the one who are the most effective in bringing the outcome of the of the situation, or when there is a problem, or when there is an emergency. So this is some of the features, some of the characteristic of the ideal team player. Has a clearly identified and agreed rules. So he knew that if you are agreed to do the scrubbing today, this is your rule. If you are agreed to do the airway, this is your rule. So you stick to it and you do your rule, and everyone will do their rules so they achieve the goal. Is adaptable if things change. If I don't need you on the head, I need you to put a cannula. If you are an anesthetist, because there's more than one, you do that. The same thing for the other members. Communicate it clearly. You have to say what you are doing and communicate to the other member of the team what's going on. Mutually supportive to rest of the team, very obvious. Feel comfortable enough to voice an opinion. That is a very important point. It has been coming in multiple incidents happened that people just like, the whole human factor came up when this woman had needed to have a tracheostomy emergency, and nobody was voicing up that there is something not happening, and the whole things went wrong. So anyone who is inside the team and working inside that environment, if you see that there's something is not, if somebody is overlooked, you think that should happen, please voice your concern, because it doesn't mean that there's a senior consultant inside the room, then everything he knows or she knows. No, it means that we are all human. We all have moments of forgetting things or something we haven't looked into. So every member of the team is responsible of voicing concern, saying what they think, because unless you tell me that there is something wrong, how would I know? So because if it's give it to you, that will not be helpful in helping us to treat the patients correctly and save lives. And always, this is a self-reflection. You have to review your own performance after each scenario, and you see that when we do these simulation scenarios and on site, the member of the team who are doing, we are asking them to give a feedback about what they have done, what they think they do better, because it's important whenever you do a task, you always reflect on what you have done, because there will be always a way of how you can do things better, because this is for self-improvement. Now, the other important thing which I mentioned about is about situation awareness. And situation awareness, I am going to just mention it in a few words. Look at this picture. I don't think the friends on that picture is aware of what is going on. Just happy with what he got on his hand. So situation awareness is very, very simple. It's a perception of the element in the environment, the comprehension of their meaning, and the projections of their status in the near future. So it is very important, 3 components. You have to perceive what's going on, you have to understand it, and then you have to think about what's going to happen. It's very, very important. If you are going to the room and the patient is bleeding, you should understand this is a critical situation. The patient is bleeding. You understand that this is an emergency situation. You need to prepare blood. You need to have more help. You need to maybe go to theaters. And this is the planning. You need to go to theater. You need to do these things. So this is all happening at the same time. And then during that time, things might change, might get worse. Then you have to change your planning as well. So it's very important. Situation awareness in an emergency anywhere, it's very, 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 very important. And this is what I told about the pilot view. And I think we will all know that when you go to an emergency and you see that there is something going on, if you see a lot of people are doing the task and they are engaged, somebody, normally this last one coming or the most senior one, just stepping back and look at what's going on. Okay, I'm coming to the theater, there is an emergency, this patient is bleeding, this patient has a lot of people around her, then you have to start thinking, okay, have we done this, have we done that? You have to have the A, B, C, D approach. Is the mother is okay, is the partner is okay, is the baby is okay, is the whole member of the team are okay for what they are doing, they know what they are doing, if there is anything I can change to make things better. That is very important. And once you evaluate that, then you have to communicate to everyone. And if there is something need to be changed, you have to change and you have to delegate the task to the others members. And I think this is the other thing. This is the Swiss cheese thinking of an error. It happens because of miscommunication. I think that something has been done before me, and I think that the other person has done it. You always has to go from the start. And a lot of incidents had happened because somebody has just relied on somebody else's information. And one of the incidents happened here is that because the surgeon relied on the X-ray report that this is the site of the operation, and he start operating on the wrong site. Is a never event. So this is, don't rely. You have to check yourself, then get the information from the start how it happens before you proceed. So always check and recheck. I think this is the last slide from my talk, and Zoe is looking at me, and she said that I am overrunning, I think, for 5 minutes. Is that right? That's fine.
We're on time.
Good. So if anyone has a question or put a hand, is that right, Zoe? How we are doing it? Yeah. Put a hand and we can answer the question. So if no hands raised, either they are asleep or it's comprehensive. Okay. Yeah, that's fine. So if there is no question, then I think what we are going to do next, we are going to run a scenario. This scenario is running our, as I mentioned, running our labor ward. It's done with the member of staff you will recognize. And yeah, I think what I will ask all of you to do is that just look at the scenario, listen to what's going on with that team, because after that, I need you to tell me. I will ask individuals, if there is no one volunteers, to comment on that scenario, how it's going, because the whole thing is about your comment on that scenario, what had happened in that scenario, looking at the human factors, looking at every single thing I mentioned in the previous slides, and then I will ask our colleagues, the pilots who are in this meeting as well, to comment on it and give us their thought about it, to get the benefit from this video. And as I said at the end, Mr. Gordon will give us a short presentation about the scenario and just a highlight of the important points. Okay, Zoe.
I'll show it from this side. If you would like to take a pen and paper so you can write a few things that you will notice during the video, that's really helpful, so we can create a conversation afterwards. Okay.
Wait for a coffee.
Yeah, I've just pressed the button. I'm just pressing the button now.
Yeah. I'm going to sit here, yeah? I think you're okay, I think. It's going to be all right, that's right?
Yeah.
You're happy with that, that's right?
No, I just feel really weak.
Well, yeah, I think because we were just coming back, I think you're tired,
I know,
Yeah.
I think so.
Where she went this midwife? You just delivered,
I don't know, I've just delivered. Yeah. But just call her.
Yeah, call her, see, Must be missing her coffee now.
Yeah. Hello, so I got this one.
Yeah, hi, listen.
Hello. Hello.
Hi, how are you? How are you?
How can I help, Maria? I feel really weak. I don't know. I don't know. Okay. Honestly, and I feel wet. Okay, that's fine. Bear with me. I'm just going to put some gloves on.
You were having coffee, is that right?
No, we've been very busy today.
All right, sorry.
Okay. Congratulations to start with. Oh, thank you. Okay.
Oh, this stuff is terrible, huh?
Have they done a COVID swab?
I think, yeah, when we came, yeah. I don't know. Yeah, the temperature as well.
Can I have a little look down below? Of course. Yeah. Oh. Okay. Alari, I'm just going to an actual exam for a moment? Can I have a little bit of your uterus? Okay. I'm just going to remove this income from underneath you. Lovely. I'm just going to pop it to one side. Yeah. I'm just going to call my colleague to come in and help, if that's okay. If I take the baby, Larry, is that okay? Is it too early? Yeah. Thank you.
Almost took time for them to come in, huh?
That's okay, they're on their way. Just looks
One day I think it's longer.
They just have to make sure they put on their
Oh, that's with all these things, huh?
Hello. Hello. Hi.
Sorry, I think the voice is not clear. We are trying to correct that. Are you hearing the voice from the video? No? Yeah. Just going to restart. Can we go backward a little bit?
Yeah, okay. In case she does it can be measured now. Yeah, please.
Can we get the emergency bed, please? Thank you. Hilary, how are you feeling, my lovely? Okay, what we will do is we will put the bed down.
What are these people, you know? Oh, she's not well, huh?
Okay, my lovely. So what I will do is I will put the bed down.
I'm very one of the effective doctors.
You alright? I will check the blood pressure.
Hello there, this is Larry. Larry delivered half an hour ago. Hi. We need to get this measured. Are you happy to measure? So we're just going to...
What can I do with the baby then?
You just hold the baby.
Oh,
Yeah.
this? Okay.
Have you got a name?
Not yet, I think the baby. Is she okay? Is she
She's
okay?
okay.
Yeah, you're right.
Okay, let's have the oxygen, please.
Oxygen, why? What's going on?
Okay, I'll tell you the effective registrar. Okay, in case she does it can be measured now. Yeah, please.
Everything was normal, you know?
Okay. So
She's trying, is that okay?
Yeah, you just want to make it and we'll keep you updated about no concerns about pregnancy, everything is normal. Having sent her with
Do you mind to describe, please?
her uterus is
Larry, are you alright? Are you okay, Larry?
Hello, I'm Lenny, I'm one of the doctors, can I take over? Alright, so what have we given in terms of medication? For the bleeding? Just had one ampoule since registered on. Okay, fine. Have we got any other risk factors for like blood pressure or anything like this? Okay, so can we get some connection, please?
Yep.
Okay. And did you also get an oxytocin infusion?
Yeah,
Who's coming now?
Oxygen, a lot of doctors.
Okay, so your uterus feels a little bit boggy, so I'm just going to examine you, if that's okay, from down below.
Brother, the pH box
Thank you.
and the symptometry.
Perfect.
Oh, in the book.
Okay, so just having a look down below, there's quite a lot of drops there that I'm evaluating. I'll need someone to measure, please, another measure.
First time, I don't know how.
And could someone please get some IV access?
Sure, I can do that.
Thank you.
I'm one of the
So,
anaesthetists.
thank you, Emily. So if we take some blood, so if we take a full blood count, UVLFT, glucose phase and a clotting with fibrinogen. Okay. And then if we put up a bag of fluid as well. Have we got recent obs on this lady?
Yes, it's 106 over 60.
Okay, and her pulse?
And her pulse is 100.
Okay, all right.
And the
Okay.
air was currently 652.
So we're at 650.
Is she okay?
All right.
Okay.
So
I will, and then I will go back to tell you.
Thank you. So just for over 500 mils, could we also give some calisthenic acid, please? Yeah, I can get that. Thank you. Want to just get a catheter, please, to put inside for the lady? Right, okay. So we're just going to keep rubbing the check. So have we given any of the medication so far?
I'm just giving a gram of tranexamic acid.
Have we given the symptometrin?
We've given the symptometrin.
Yeah. And have we got the oxytocin infusion?
They're preparing
And preparing it, and that's running. Perfect. And we're giving the TXA. We've got fluids running. Yeah. And we're about to insert a catheter. Okay. Use the system.
Okay, so Zoe said that we are done. So that's the part of the scenario we are going to run, because I think that's I think enough for our discussion today. So anyone want to be to chip in and say what they think about the scenario? Of course, what we are looking into when we are going to discuss any scenario. The first thing that I want first round to say that anyone tell me about positive things in that scenario, whether that team members or as a team or as individual. So if everyone can tell me one or two things that he found in that scenario, which is done correctly in a positive way. Yeah.
They did seem to stay calm.
Yeah.
And were listening to the main doctor when she came in.
Okay. Anyone else? Thank you very much. Yeah,
I can talk, Kaskos, if you want.
Yes, yeah, please.
I think that when the doctor came in, she took control.
Yes.
Yeah,
yes, you are right.
Control.
Okay, anyone else? Yeah, Claire?
Yeah, I was just going to say that there was a bit of recapping. So it was kind of, have we given these drugs? So recapping what's been given, having a kind of getting back on summarizing what's been given. And I thought that was good.
Yeah, thank you. Anyone else?
Yeah, I think everyone had a part to play there, and no one was just standing and watching. Everyone had something to do.
Yeah, excellent. Yeah, it's teamwork and yeah. Brilliant. Yeah, good point.
I think the initial response, if I can say, the initial response for the first nurse for rapid recognition of the problem and asking for senior helps from the other team. This was the main thing, more important thing, rapid recognition and calling for seniors.
Excellent. Yeah, escalation. Ask for help. Yeah, excellent. Any more, please? Any hand? I need more.
I think there was a trial to engage with the relative, but it didn't seem to be enough.
Yeah, we will talk about the things which need to improve. I understand. And what I want today, I mean the positive things. I think we have mentioned that few things, that the first nurse was knowing what she is or just escalate. Team is doing what they can. They are calm. There's communication. There is also some palliative view. Yeah, Naj?
There's a good going delegation going on. The doctor delegates the tasks of cannulation, taking the blood, and one of the midwives calming the dad. So I think that was good.
Yeah, thank you, Naj. Nimisha?
There was a scribe. I think the roles were kind of assigned sort of quite seamlessly, it seemed, without anyone actually going through and saying, right, you're going to be the lead, you're going to give the drugs. It just, everyone seemed to kind of take up their role quite nicely. So they're obviously a team that worked together.
Thank you very much. Yes, good point. Karina, I saw your hand.
Yes, when the doctor did mention, has anybody done blood pressure? there was an immediate response, which means everybody was on board. And there was a point in time she actually asked for something to be done. She said, can somebody take this? And somebody immediately said, I will do it. Based on what you said initially, that when you say somebody do this, then nobody does it. But that was very, very clear that immediately she said that, somebody pointed and said, I will take care of that. So I thought that was a good point. Thank you.
Yeah, thanks, Karina. Any more points of positive of this scenario? Any more hands before we move to the points that we can improve? Naj, is this another hand or the same hand?
Same hand.
Ah, thank you. Okay, any more hands? Okay, so now I think we are mentioning the good thing about this scenario. I think they are doing the right things. They know what they are doing. Now, I want to know if you think about anything that we can improve, even if it's a minor things that we can change, which can make this team or this scenario run in a better way if you are going to do the scenario yourself next time. So I would like to hear from the colleagues about what they think that we, or the criticism or a point that to this scenario when the team or a leader they are doing it that we can improve. So yeah, who is going to go first?
I think I already mentioned the communication with the relative. This is the first point.
Yeah. So I think, go ahead and explore more about the communication. You mean about with the partner, you mean?
Yeah, with the partner. He was sitting there making them more worried, keep speaking, keep disengaging with the management plan for the patient. So if someone from the initial steps taken him away, I mean outside the room, and make him more calm rather than keeping inside the room with everything is happening, it would be better. The other thing, I think, I don't know if there's any initiation, any emergency bottom inside the rooms itself, rather than going outside and asking for help. If we have a bottom inside the room itself, the emergency one.
So the emergency button was inside the room. If you know that, Ahmed, that inside any labor ward there is an emergency button. So just
can activate it rather than going outside, leaving the patient.
Yeah, that's what they did.
Issue. Yeah,
that's what they did. Yeah.
Oh, okay.
Yeah, that's what they did, because I think you might be confused, because there were two bleeps. There were the bleep of hold by one of the doctors, and there is also the crush call, which is just you are pressing a button inside the labor ward. Yeah. Nicola?
Just to watch the language, really. So they were explaining to Mum that her uterus felt a bit boggy. But that doesn't really mean anything to Mum, so we need to be careful about the way we're making.
Correct. Correct. I think the communication should be clear. We should not use words that is not understandable by the others. We should be, yeah, Claire?
I was going to say that I don't.
Sorry, can we have everyone on mute, please, unless the person is talking, please? Excuse me, can we have all on mute except the person who is going to talk? There's a lot of noise. Thank you. Yeah, Claire, sorry.
Okay. So I don't think that there was a clear kind of assessment of the volume of blood that was that I didn't hear that. I don't know if they said it, but there wasn't. I know they talked about measuring it, but there wasn't kind of this is a major PP. You know, it wasn't clear from the scenario what the assessment was of the volume of blood, and I think that was missing.
That's correct. I think that's a very important point. When you go, that's what we say about situational awareness. You have not only to mention there is a bleeding, how the severity of the bleeding, how much she's bleeding, for how long, how much she lost, what is her hemoglobin. That's I think an important point. Yes, you have to. This is what we mean by situational awareness, and you have to mention it very clearly. Yes, Rashi.
I feel at a lot of places the communication loop was not closed. I mean, as if something was done, it was not told that it is done already. So there was a bit of confusion.
Yeah, correct. That's an important element. When you say something, you have to ask the person in particular by name, what it has happened, and they have to feed back to you that there will some issue with that. Yeah, Amila?
I think, yeah, as you said before, someone should step back and take control of the whole picture, delegate tasks. I think that's quite important, like either the anaesthetist or the obstetrician, one of the team members stepping back and making sure that every task has been delegated and completed.
Yeah, I think this is the pilot view. It wasn't obvious for this scenario because I think it was important that somebody will go back and said what we are doing and then look. But it is, yeah, it wasn't obvious for you. Yes, okay. Any more points? I just want to highlight the point, what the view of the others about the partner inside the room. Do you think that it is the right things or we should take him out, or what do you think? Can I hear from the colleagues who haven't commented yet, please? Because it's part of this course is that you will have to be involved because it's not only me. Yes, Tim?
I mean, you have to look at the partner and the scenario, the situation, and decide what is best for the patient, what is best for the partner, and what is best for the staff. Looking at that one, I would say that probably one person should have taken him and said, look, we're a little bit busy in here. I think it's probably best off, and somebody go with him and take him somewhere, talk to him, explain exactly what you are concerned about and what you're doing, but keep him out of the room, because I think he was getting a bit worked up. And I think he was a little bit counterproductive in the sense that he was interfering with people's thought processes. If they're calm and they understand, keep them in the room. But if they're starting to become counterproductive, I think best thing is take them out, but keep them informed.
That's exactly what we should do. Thanks, Tim. So that's exactly the view about this situation. If it is a stable emergency and things are not quite going in the bad direction, on sometimes it's good that they are staying there, but when it's become destructive and they are going to disturb the care you do to the patient herself, then I think at this point you have to separate it. Exactly, that's what that's the right approach. Thanks, Tim. Yeah, Nicola?
Hello, can you hear me?
Yes, I can.
I was just thinking also sometimes when situation like this arises, the mother might panic too. So sometimes it is better keeping the father in there so they can, focus on the baby and themselves together, and then we can get on without. Because I've noticed with our midwives, I'm from Frimley, they're very good. When I get there, the father is and the mother, most of the time, they're talking to her with the baby and we're fussing around them. And the midwife has already discussed it and said, listen to the dad, obviously, because they're very calm. But I think the father does calm the mother down as well, and they're a little team. They can focus on that, I think. But yes, it's definitely, if the father's panicky, then no, maybe he should.
Thank you very much. So, Ayat Muhammad?
Yes, exactly. Can you hear me?
Yes, I can.
I have a view in that is that sometimes it depends. There's a great personal variation in that, and sometimes the partner might faint or might collapse when he sees that there's a situational that is no control, or there's an amount of bleeding that he sees coming out of his wife. That might be causing a lot of mess in the room. That the partner has collapsed. The mother is bleeding, and the baby in a disaster situation. So I think that it's different from a situation from another. Sometimes the partner can be adding to the positivity of the whole situation, and sometimes he's not.
Yes. Can I just say there are other points in this scenario which could have been done better, and there are a lot of things which we can improve. If somebody else can highlight these points, a good observer will let me know, because it's written in my paper, because we observe it and put it there. If there anyone who can tell me more. So you notice that this patient is COVID, isn't it? So she has coughing, she has symptoms of COVID. We did this scenario to integrate COVID. Do you think that the measures has been taken in terms of COVID were all correct, or there is things that we can do better, or This is one of the things which we try to highlight in this scenario. Anyone? Sorry? Okay, anyone? My colleagues who are in the room at Wexham?
But what I see is that all the persons involved in
telling the sister
were for PPE.
but they didn't know she was there.
Received this cover.
So you so you notice that they have mention of that she is coughing, and they are mentioning about swab. I don't think anyone had mentioned about if that's confirmed or not, whether this patient is in the right place in terms of what we are doing. I don't think there were confirmation about it, and it's important at this stage when we are in. Well, we are getting out of from the second wave, but it is important to know if this patient is COVID or not and what we are doing. What about the PPE? Is it the right one that we were?
I definitely had that.
Yes, Nicola?
Yes, there were all different PPEs going on there. One, I think the doctor wore PPE, and the two original midwives were just with face masks. So
Yes.
it's a very, everyone was doing different things.
So what do you think? Which one do you think is the right one?
So I think you must remember, so as the anaesthetists coming in, I think we would ask before we even go in, COVID or not. But I think I assumed that the midwives not in PPE had done the swab, and a very bad assumption. But because they're not in PPE and they've been dealing with this woman coughing in the room, I'm assuming maybe she was negative.
So we assume.
I don't know. I think I would dress up, because
Yeah.
if she's coughing like that and I haven't got a confirmation, I would put PPE on. But I mean,
so you see that the team are assumed something. They haven't confirmed. And
Yeah.
we always say that you don't assume, you have to confirm. And if you are in doubt, you have to go in the most safest way to go. So if you are in doubt, you don't know, you have to treat this patient as a COVID until prove otherwise. So we know that in maternity, you don't have that green pathway, the one that we have in other elective work. So when you go there, for me, they are all amber pathway until they are proved that they have no symptoms and they are COVID negative. For this patient, she is COVID. We don't have the status yet, but she is coughing and she has a temperature. So we should assume she is a COVID positive until proved otherwise. And I think this is one of the points in this scenario, that the team assume that okay, it's fine, and they're all acting in different PPE. There is no, each one is wearing, and you see that the midwife came in. She didn't put the gel on her hand. These are simple infection control, but I think these are important to highlight. We just had in a meeting, a consultant meeting, and it's highlighted to us that the infection MRSA at Family Health in general is not a good status. Well, we are talking about MRSA, but this is another infectious disease. So we should all follow the guidelines for infection control, because these are very, very important. We should always follow them, because otherwise this is COVID. The COVID will be disseminated everywhere. And we had a lot of outbreak inside certain units in the trust here and there, because people, they don't follow the guidelines. And the best thing is that being safe. And I think me and Monica, we talked a lot about these things and safe, and we talked about it a lot, because I feel it's very important, because it's not about you, it's not about me, it's about all of us. And I think when you go and see the patient, you have to think about the safe approach to look after her. There are a lot of points inside that scenario where there is no clear what they are doing about PPE. Any other question about the handover? Anyone can comment to me? How was the handover between the team? I need a comment about that. Can I ask by name then? Zoe, can you ask by the name for people who didn't involve yet? I can't see all the name. Nicola, you go. You are very good. You are very good. We give you extra point.
yay! Well, I think thank you.
It's
Don't
very important.
encourage her.
It's very important. It's very
Do not
important to
encourage
participate.
her.
I think, Shane, they did their best, because I know the scenario when you get into a massive hit, well, not massive, the bleed is difficult, but there needs to be a bit of a brief handover. Say, listen, this is this person, this is that. I'm finding there's plus minus on the sheet so much blood loss, and also what I've done so far in the procedure. Yeah. Like given the Cinto, why must I mean the poor doctor had to ask, what did we do? I mean, this is pedantics in particular, but the doctor had to ask. Sometimes we just say, I've already given this.
I can't hear you, Nicola.
Sorry.
Yeah.
What part did you get? I just
Yeah.
said it's pedantics, but sometimes you really do have to be specific. I have not, I've given the tranexamic or I've given the oxytocin. It's definitely the drugs that you need. And what you're finding is the uterus, or is it just a bleed, you know, because she felt the uterus up. So she was feeling if the uterus was, and where the source of bleeding was coming from, maybe.
Yeah. What else about the communication, about the handover? Yes, Tim?
I kind of like to involve the patient in the handover too, so they feel like they're part of it, and it also makes you. It's a way of communicating to the patient and to the staff the same thing, and also reassuring the patient at the same time. So when you're handing over to somebody about what you've done or what you're planning to do, to involve the patient in it as well and talk almost in patient terms. This is Sally, who's had a bit of a bleed, and we've just put a drip in, so that she feels like everybody knows what's going on and she's part of it.
Yeah, excellent. Thank you. Our pilots, Dave, are you online? Can you, Dave? Okay, let's go to Claire. Dave is here. So let's have our Dave Phil, as I mentioned to you, he's a human factor champion. He's teaching in our simulation course and very kindly agreed to come and join us today. Many thanks for joining us, Dave. And it's all yours now to comment on the scenario and enlighten us all about what you think about that scenario. I can't hear you, Dave.
It keeps muting. It's got a life of its own, this.
Now it's okay. Now it's okay.
Yeah, good. Thank you. First off, Alex sends his apologies. He's actually doing a sim at Whittington this afternoon. So you've got me flying solo on this. How exactly do you want me to play this, Dr. Kaskos, in terms of, do you want me to go through what I see as the negatives, the positives, what was done well, what was not, or respond to some of the stuff that's been raised in the discussion?
Whatever you think is the right things for our team, the way that just have a summary of the whole scenario, what you think it's done in the right way, and the things we should do better from your perspective as a human factor, looking at the scenario. You are not a specialist in obstetrics, obstetric anesthesia, but you are just looking at the human factor coming there.
No, okay. And this ties in just to the background of those who don't know what pilots are doing, getting involved in this sort of thing. This is we're obviously not doing a lot in flying aeroplanes at the minute. So it all started with the Project Wingman at the lounge up at the Whittington. I believe you had one at Wexham as well. And we got asked to go and observe a sim up in ED about last May, June. And we just wrote some observations. Didn't say anything at the time, and they seemed to go down very well. And that's led to a sim observation program, which has expanded out to Wexham and one or two other places as well. And we've now observed over 90 sims now. So to begin with, we hadn't the faintest idea what you guys were talking about. We've a little bit more of a better idea. We know our rocks from our ROSC and things like that. But what we're interested in is not the technical aspect of things, not the words that are used, but how they're said, and the way that, because the teamwork is very different in a clinical scenario than it is in a flight deck or a simulator, which is actually a very ergonomically perfect environment. So it's just the human beings that interact with each other, and we recognise that it's very different. You guys may be operating in different parts of the hospital with different people in the team, and there's a degree of flexibility needs to be shown there. In terms of this particular scenario, I think it's worth pointing out that a lot of stuff was done well, because it's easy in these situations to be quite pointing the finger. Well, what about that and that and that and that? It's worth saying that the degree of calmness, I think, particularly for the first team member there who first uncovered and found that blood-soaked blanket, I thought was extremely calm. It would have been quite easy to betray a slight raising of the voice or anything like that, just to instill some degree of panic's the wrong word in the mum and the father. I thought that was very, very professionally handled, and I like the fact that there was someone there at the back scribing, taking the notes of the dosages and times, and also reading out the checklist. I think this is something that's often missed in these scenarios that we've watched, is delegating the task of keeping an eye on the time. That's obviously going to be very important for something like a cardiac arrest, where the 2-minute cycle is pretty critical. So, and what that does as well is it gives a structure to a scenario. And the key when I think things get chaotic is to have a structure. And that can come from a number of different sources. It can come from strong leadership, which is, we'll come on to that in a second, but it can come from other little things, like someone keeping a time. If it's a time critical scenario, having someone dedicated to looking at the time. You are picking up. Somebody going to the toilet in there? I think we all need to turn the mics off.
I think it might be took his phone with him, or her with him. I don't know, with her, something.
I didn't think my talk was that bad that it forced people to go to the toilet, but there we go.
I am enjoying it.
So yeah, so the timing is good. Scribing is obviously good for record keeping. And I don't know whether you noticed, I presume that was the PPH protocol that was being read out by the blonde lady at the back.
Yes,
Am I
correct
there?
Yes, correct.
Did you notice the sort of structure that gave to the scenario? How it actually gives everybody's comfortable with something happening. The scenario is going somewhere. It's being driven. And that's where checklists and protocols are so useful. I mean, obviously we live by them in aviation, and everything we have, everything we do pretty much in troubleshooting and routine stuff is governed by a checklist. And there's a number of reasons for that. Is that, and obviously the human body is way more complex than an aeroplane. An aeroplane was created by humans, and humans have actually worked out what things tend to go wrong with that beast. So occasionally we will need to improvise, but generally speaking, we use the checklist. And yes, it will sort the switches out in the right position and shut off things that need to be shut off, etc. But it gives structure. It gives it engages a slightly different part of the brain, the frontal cortex. So it's rather than anything that's emotional in the amygdala and all that sort of stuff. So the structure that a checklist brings, not only does stuff get missed, and the beauty of checklists is that performance arousal curve. It stops things being routine things being missed because you're bored, you're complacent, you're under aroused or whatever. For us, it's the middle of the night and you're tired, and you're likely to miss things just because it's not routine. The other end of the performance arousal curve, when you're over aroused, when you're stressed and there's a lot going on, and that is when there's errors of omission. Stuff gets missed just because you're stressed and there's things happening. And that's particularly where checklists really come into their own, because it's a method of slowing things down. If a scenario is starting to run out of control, then a checklist is a great method of actually bringing some degree of control and pace back into a scenario, because you can judge either if you're reading the checklist or it's being read to you, then you can control the pace of which you actually give those responses. So that's a great way of actually grabbing hold of control of something that threatens to run out of control if the stress levels go up. So we love checklists, and I think what was particularly good in that scenario was the way that the checklist was being read out from the back, because everybody is comfortable with it. So that's a form of structure. So two things I could talk about a lot, bits and pieces here. let's try and bring it all together in two things. The lead. I'll talk about lead and I'll talk about distraction management. In terms of the lead, we are meticulous in aviation in making sure that the chain of command is clear and that someone is always in command of the cockpit and someone is always flying the aeroplane. And we've often seen in scenarios that it's confusing when the lead is not very clearly enunciated. Now, I think in this scenario, it was clear who the lead was in terms of the doctor. But we would always recommend, as a good practice, it's so easy to verbalize, I have the lead, or you have the lead, or actually clarifying who has the lead. And that the issues come, there's two parts to that one, as we've seen in our sims. Firstly is when you call for someone more senior, there's the term is handover, and that's been used today already. It's actually an unfortunate term because a handover implies you are handing something over, which is usually the lead. And that might not necessarily be the case because you may have called for help from someone junior or equal of status for you. But by giving the handover, that we've seen confusion as who's actually got the lead at that point. And particularly, there's two cases there. If you're handing over a registrar to a consultant, for example, or anybody to anyone more senior, it may be the case that the consultant doesn't necessarily want to lead it or is very happy to let the person who's called for help and called for more assistance to carry on leading that scenario. They just need more assistance in terms of knowledge and all the rest of it. That doesn't necessarily mean that they want to hand over the whole scenario to them. It's a tricky one when you go registrar to consultant, but it can be resolved with a discussion. Simply says, here, that's the brief. Are you happy for me to carry on leading this, or do you want to take the lead? It's a very quick discussion that can resolve a lot of ambiguity. And the second occasion is where you get people of the same grade coming along. And that's where we've seen that could be a trigger, red flag type moment. If you have a difficult airway and you call for anaesthetic help or ITU help, and a similar grade comes along and you give a handover brief, it's always worth clarifying who has the lead, who has control, because there needs to be one. And we have certainly seen scenarios where it's been an ED scenario. They called for help from the from the anaesthetic department because they need intubating. But then the two registrars, same grade, but then it's never been made clear who's leading it. And the nurse has been left like Wimbledon. It's like, OK, who's actually leading this one? And I remember vividly one scenario in one hospital where the nurse just said, well, I don't know. I just waited for someone to shout an instruction at me. I had no idea who was leading the scenario. So that's the view from the other side of the fence. And everybody responds, particularly in a chaotic situation, to someone being in charge. It doesn't necessarily have to be the most senior. It just has to be someone clearly stated. So in any form of scenario, Dr. Kaskos actually talked about leadership and the importance of being in control and all the rest of it. It is so critical. And the more chaotic a situation, the more people if there's two or three of you, that's much more easily sorted out. But if it's a big team situation with lots of people around, that's when it becomes super critical to nominate who the lead is. Second point is distraction management. Distractions are one of the biggest causes. Poor communication error. Poor communications counts for about 70% of aviation accidents. That's why we're so keen on the use of words, on the read back principle, which those of you who heard me talk before, we go on about this incessantly. Any critical instruction should be read back. That can be a drug, it can be a dosage, it can be a task allocation, because it's so quick, it's so easy to do, and it causes, it's an extra safety layer that's put in the communication process that we just scratch our heads and say, why would you not do it? And the standard response to an instruction, say 200 milligrams of hydrocortisone, seems to be, yup. Can you see the problems in that in a very stressful scenario like we just saw there with lots of people talking at the same time? If an instruction's given out, how do you know that the person you're giving the instruction to has heard it and that they've actually got the right drug and the right dosage? And unless they repeat it back to you, you're never going to. That's a link in the community. That one of those Swiss cheese. That's a hole in the Swiss cheese if that's not repeated back. And the example I will give to you, just in total, it's non-clinical, is when you go to a restaurant and there's a table full of people and the waiter takes the order at the table, what does the waiter do? Reads back the food order. Why do they do that one? So that the wrong food isn't delivered to the table. And it's exactly the same principle. And if you want to just go and listen to some air traffic control stuff, you can type in Heathrow air traffic control approach and you'll get the live feed. It's maybe not that busy at the minute, so it's possibly not a good example, but if you've got some spare time, just type that one in. And that because we don't have anything visual, we don't have body language, we don't have eye contact or anything like that, we just have words, and words are really critical to us. And so we enunciate clearly. We actually will have a phonetic type of alphabet. We choose our words really carefully. We don't say yes or no. They're too short. They can get lost in a dodgy radio, a crackle, an interference, something like that. We actually replaced yes and no with what used to be affirmative and negative. And this is the detail we got into. Then we realized we hit problems because people were just hearing the if at the end of those words. So again, we changed it. So it's now affirm and negative, so that there is absolutely no doubt what you are trying to communicate with those words. And it's not 9 and 5 because you just hear the I sound. We actually say 9er and 5 is the way. So actually, you know, the American, whatever it is, just saying, yes, 2 9er, 9er, or 5 is actually there for a reason. It's correct so that it's crystal clear. I'm not saying this is something you have to do. I'm just illustrating it's for us. It's important. We treat this stuff so critically with words. And that's why we always repeat back. And air traffic control will not let us do something if we don't repeat it back. So you'll hear if you type into that website an instruction, say Speedbird, that's a call sign for an airline. Speedbird 123, turn right heading 220 degrees, to which the response is turn right heading 220 degrees, Speedbird 123. And if you don't give that instruction, if you don't read it back, then air traffic control will pull you up on it. The Americans are hopeless at this. They'll come in and go, Roger. And the British air traffic control will say, American, whatever, read back, please. So they will pull you up if you give poor air traffic control, if you give poor RT discipline, because it's important. So I would urge that as a practice. It seems slightly unnatural, but a lot of what we do in it's not natural to wear these, for example, and it's not natural to wear scrubs to go to work. So it's when we adopt our work clothing, it's almost adopting a mode of behavior. And so it may seem unnatural to repeat it back, and it's not a question of trust, and it's not a question of you don't believe me and you don't disrespect me for not knowing my stuff. Did I not hear you properly? It's just a safety check. So we would urge that one. And I got led on from, I got distracted from distraction management. Yes, this issue with the patient is a really interesting one. When anything that's pediatric, we've done a lot of CAM sims, and it's a big question. Tim pointed out there about involving the patient. Same with us and passengers. If they're not involved, they can become a problem. If you have an engine failure and or some sort of technical failure, which is obvious to the passengers, and you don't say anything over the PA, you could get a riot. You cause real problems for the cabin crew because all the passengers are wanting to know what on earth is going on. And so a well-placed PA, good piece of communication that actually explains what's going on, and in a sort of even a regular update. You've all been passengers. You've all been in a delay situation. What is the thing that irritates you the most when you're sitting on an aeroplane on a delay situation? It's not knowing what's going on. Nobody's talking to you and you haven't a clue. You can't make plans, make phone calls or anything. So if transfer that to a patient situation, all this stuff is happening in the room and nobody's talking to you. So how does that then make the patient or the relative feel? So what I would urge is, if your resources allow, and this is one thing that was sort of happened in this scenario, the blonde lady did at one point talk to the father, but then stepped away and left the father literally holding the baby. If the resources allow, having somebody task dedicated to looking after the parent or the relative will reap so many benefits, because it actually takes them out of your hair, and it adds another dimension to the question of do they stay or do they go? Because if they go, they could, if you take them out of the room and they don't want to go out of the room, that causes a problem in itself. And if they stay, yeah, it's a distraction. And if they kick off, it's going to be a distraction for you. Having someone dedicated to them whose task is to interpret, to translate, and to keep them calm could turn a potential distraction into an asset for you, because they can then be used to calm the, I think Nicola mentioned the patient themselves. Just because they are calm doesn't mean to say that they're necessarily feeling calm. They may be seriously panicking about what's going on, and actually having the partner there working for you because they've been briefed, and actually taking them out of an emotional state, and again using the thinking part of the brain, offering them choices. If you stay, I need you to do this. I'll keep you updated on this, and the job that we want you to do is to keep your partner calm. From a distance, you can't be there, but encouraging words, etc. Task allocation, keep them focused, and you'll turn a distraction into an asset for you. So time spent actually thinking about the parent in a situation like this is going to be time really well spent, because it won't take away your time later down the downstream when they start to become a distraction for you. And the other thing that allows you to do, because the subject of language was brought up as well, about the uterus feeling soggy. We are always taught, be really careful when you're talking to passengers about use of technical language, because pilots are like doctors. We love our acronyms, with 3-letter acronyms. We love our techie talk, and it can be gobbledygook, and it can be confusing for the passengers and can cause more issues than it solves. So we're always taught to be very careful with our PAs to passengers to avoid the use of technical language. And so it's going to be similar when you're addressing a patient, and we've seen it a few times of actually just casually throwing in drug names, which is absolutely commonplace, and you understand what's going on, but the patient might not do. And so just thinking about, it's almost a translation. It's not dumbing down, it's just using words that are commonplace rather than very technical. And the other final point about having someone who's sort of the translator for the patient is that it's always this really difficult issue. If the patient's unconscious, yes, as a team, you can sit and you can stand and discuss options and talk about the severity scale of things and work out your plan of action, bouncing ideas off each other if the patient's not listening because they're unconscious. It's a very different matter discussing a diagnosis and a plan of action as a team when the patient's conscious, listening to everything you say, and could be spooked. And if there's a parent or a relative there as well, adds the other dimension to it. So it changes the way that you communicate. And having someone there who's translating really helps in this regard, because it allows you to carry on and talk as you would want to talk. And if the parent picks up and says, what do you mean this is really severe? What do you mean you have to take them to ITU? Does this mean they're going to die, etc.? Use someone right there next to them to say, absolutely no, this does not mean this. This is simply a precaution, etc., etc. So it takes away any worry that you have about being distracted by the parent, and actually allows you the space to carry on and do the diagnosis and the severity and get the marks of severity, because that will adjust the time frames that you need. Does that make sense?
I'm really enjoying everything you're saying, Dave, and I'm sure that my colleagues who are in the room here with me, they are enjoying it as well, and they want you to talk more.
You want me to talk more?
So I'm just going to ask the colleagues if they have any other comments while Dave is also with us. If they have any issues of this scenario we need to clarify about the human factor, we can also highlight it now. We have another 10 minutes of this discussion before Mr. Gordon will give us a lecture. Andrew, you have done a lot of simulation, human factor. I know you are not obstetric anaesthetist, but that's from a view of If you are working with the simulation, with the airway and things, what do you think about this scenario?
I think Dave has made a fantastic summary of everything. I mean, obviously, he's an absolute expert compared to me. I mean, I'm an enthusiast and have been so for a number of years, but Dave just brings it all together beautifully. And I think Dave and his team are hopefully going to change the culture quite dramatically for the better in the way we manage these crises. I think at the Whittington, they've made a huge difference. And I think they're beginning to make a difference with us, more in the ED. Unfortunately, we haven't been able to do so many in anaesthetics because of COVID, and we haven't had trainees available, but certainly in ED they've done regular scenarios, and I think the culture has changed dramatically, and I think they bring on board a whole new perspective on the way we manage these crises. And this business about leadership, situational awareness, task allocation is just so important. And although, as I say, I've been talking on this for years, I've learned so much off Dave and his colleagues on this matter, that these are just critically important parts of managing a scenario. You've got to have a clear leader and hand off the leadership if it does change. You've got to have good situational awareness. You've got to have good task allocation, and you've got to be methodical in the way you manage these crises. And checklists. I mean, you know me, I love checklists, but I think checklists are so important, and they just bring everything together. And I can only, as I say, concur what Dave says, because it's just completely makes sense. And I think if we embed this kind of culture into the way we manage these scenarios, they'll be managed much better and much more safely, and overall there'll be greater benefit for patient safety in the long run.
I think it's one thing I haven't mentioned, if there is an opportunity, is because this crops up a lot, and we're dealing, I presume here we've got the wide range of team right the way through the grades and specialities here. Am I correct? It's how to get that. So many instances in the NHS have been about people not speaking up, about just because the senior, they're not seeing everything, and the junior people around the bed see things that perhaps seniors miss. I mean, we're all thinking presumably of Martin and Elaine Bromley, and that the case that I think most of us are aware of, and that tragic situation whereby the experienced nurse had actually got the phoner kit out because she saw what was happening and what was going to happen. She had the phoner kit and held it there ready for use. But that final critical step was not made of alerting these senior doctors to the fact that there was something going on, that this kit was needed. And this big question, which I know is very vexing for the NHS, is how to get team members to speak up. And I know we're talking about big questions of culture and just culture and the blame culture and all that stuff, which is all above my pay grade. What I would say is it's a twofold responsibility. That first off, senior leaders almost have a responsibility to create an open culture within the team that encourages input from all points, all parts of the team, and asking open questions is really good. And it's written down in the Human Factors Manual, and that is a widely accepted principle. Open questions are good. What is often not written down is that there's a second part to it, and that means getting the answer. And that means leaving a bit of time and actually actively engaging with people in the team, looking them in the eye or asking questions in a way that gets an answer back that either isn't silence or just yes. Because confirmation bias is really easy, an easy trap to fall into when you ask a question. It's this. I think it's this, isn't it? It's very difficult to say, no, it's not. Whereas in aviation, we'll often we'll flip it round. We'll turn it to the negative. Give me a reason why we shouldn't divert to Paris. Give me a reason why this isn't a failure of the secondary hydraulic system. And that actually forces the recipient of that question to think and come up with an answer. So that's the responsibility on the one side of the leadership side of a team, to create the culture, ask the questions in a way that gets a meaningful answer back. But then there's the responsibility of other members of the team to respond and to speak up if they see something that's not right. Now we're into this am I upsetting someone type culture, and it's tricky. And we're big fans, and actually something we've learned from you is this cuss model. I don't know if you're aware of it, how you use language to escalate your concerns and severity. And it's like a series of flags that you use. And the C is I am concerned about what's going on here. And hopefully that will get the desired result, that someone will go, so, okay, why are you concerned? If that doesn't work, escalate it up one. I am uncomfortable with what is happening here. These are powerful words, trigger words that we're talking here. If that doesn't work, then we're into the real big one, which is safety. You start to push the word safety around. This is unsafe. I am unhappy with the safety of this situation. Then that's a massive red flag. And if they're still not listening, that's when you come in with stop. And that can be backed up by that gesture. That in any culture, that is a powerful gesture. I mean, it's the ultimate, not nuclear option, you know what I mean? It's the final big stick to use, and you hope you never have to do it. But actually standing in there, that in Elaine Bromley, if she'd actually reached her hand in and said stop like that, would that have made a difference? Who's to know? Because the final point there, if you get that coming from the team, from a leadership perspective, there's two really crucial words we use in aviation, which I offer to you as a tip going forward, that covers all sorts of aspects of human factors and traps things possibly before they become a problem. Two words we say: resolve, ambiguity. If there's any ambiguity in anything that you are doing, be it an equipment that's giving erroneous readings, or different people have got different opinions on something, or the actual data that you're getting from one source is conflicting with the data from another source, that's an ambiguity. And there's the word assumption has been used in here, and assumption is actually a technique, psychological technique for covering up an ambiguity. That there's something in the back of my mind that isn't right, but I just assume that I assume that it's fine. I assume that they know what they're doing, etc. So we would say resolve the ambiguity, and that means verbalizing it. Hold on, what is going on here? That's saying that, you're saying that, this piece of equipment's giving contradictory information. There's an ambiguity, resolve it, because odds are on, if you don't, it'll lead to something sticky. And there I must stop, otherwise I'll be going on for another 2 hours.
Thank you. It's an interesting talk all the time. I have been hearing you many times now, and every time I learn something additional to what I heard before. It's really a big experience, and we learn from each others. I learn more from you. Of course, this is very important. I was running this course for many years, but the human factor become an important thing, more important than any time before. And we are learning from your experience from this different field, and we try to apply it for our work. And it's nice that you are looking into it from different aspects and enlighten us on what we should do. I think Tandeep raised hand. Is that right, Tandeep?
Yeah, can you hear me? Okay.
Yes, I can.
I was really hoping you'd say affirm there, Hassan. So as an anaesthetist, so obviously I've seen many simulation and real world scenarios where various leadership candidates, shall we say, will discuss between themselves who should lead a scenario. I don't think I've often seen any other members of the team, so perhaps more junior members of the team, actually ask where that ambiguity is, actually ask who is leading, may I ask who is leading? And I've just wondered, presumably you don't get this very much in aviation, but I was just wondering what Dave's view on that was, and also whether any of our colleagues, perhaps junior colleagues who either work in theatres perhaps, have they ever been in a scenario where they can remember that they've actually asked that question, who is the leader? Because whose responsibility is it to assign the leader? Surely it's not just the leadership candidates, it's actually the team as a whole.
Just to answer that, the question in the aviation perspective very rarely arises because, as I say, the chain of command is very clearly laid out. So who is leading it is that there should never be that sort of ambiguity. You may get ambiguity over who's flying the aeroplane, and there's a couple of cracking examples that I probably haven't got time to go into now, which is why from day one in flying school, it's the expression, I have control, you have control, which Andrew well knows from all of his years of flying small aeroplanes. Whenever you hand over control, it's you have control, to which the response is I have control, so that it's very clear at any given moment who is flying the aeroplane. So that doesn't really apply, but certainly I think before I throw it open to
thank you very much.
The wider group, that there is nothing wrong with a team member if there is any uncertainty. If we're into a Wimbledon situation of orders coming from left, right, and centre, of someone actually saying, "Can I just ask who's in charge, who is leading?" There's nothing wrong with that question whatsoever, and it resolves an ambiguity.
Yeah, there is another hand from Ian.
I'll just come off mute. Sorry, just something in regards to these situations holistically is how much these normally happen around 6 to 7 a.m. after the night team's been up for probably about 13 hours. What I would just be interested in, Dave, is how long do people in aviation, pilots, go for before taking mandatory breaks? Because in medicine, I feel that we, as an MDT, kind of push these to the side, and then we're up for 18 hours without having a thought of how that affects our thought and action process.
A really, really good question. And one thing that never ceases to amaze me is that the F word is never mentioned. And by that, I mean fatigue. Fatigue is a big issue for pilots. And we have very strict rules about how long you can go, according to what time you start, how many time zones you're crossing, and all the rest of that stuff, which are supposed to be scientifically measured on the Karolinska scale, etc., etc. They're there, but that's a framework to work around. I think what we now recognise is that you are not going to be at your best at all times, and that's something that we seem to have stumbled on in the NHS. That there's assumption that doctors and nurses are supermen and superwomen who will perform at that same high level 24/7, and that is clearly unrealistic. So we will have our limitations, and when we carry extra crew members and how long we can go before we have to have a break, etc. Anything basically over 9 hours 15 minutes out of Heathrow, then you need to carry a third pilot. Anything more than 14 hours total duty, you need 4 pilots. So Singapore's, Hong Kong's, etc. The really long stuff, Santiago's, need a complete shift change of crew, which gives you your break in the flight. Now, here's the issue. You take your break in a bunk, and we do have these nice bunks, and they're flat, and it's a bit of a sky cabin, and they're all hidden, and it's great. And theoretically, you've got 3 hours in the bunk. But what happens if you're going down to Singapore over India in monsoon season, and the air is really unstable, and that the whole airplane is doing this hour after hour after hour? And those of you who've been down that neck of the woods know what I'm talking about here. The airplane will be shaking exactly like this. Well, in other words, you're not going to be able to sleep in your bunk rest if you're being bounced around. Seatbelts are on, or signs are on. We do have straps on the beds, etc. But I've certainly been braced in the bunk like this for a couple of hours, because you've been thrown around so much. You're not going to sleep, which means that you could have been awake for about 20 hours, and you are coming back into Heathrow. I fly the 380. It's very long haul stuff that I do, and a lot of our arrivals come back between 5 o'clock in the morning and 6:30 is when we do a majority of our landings back in. Now, you're familiar with a WOCL, the window of circadian low, where the body temperature is at its lowest and you are the least responsive and your brain is the most sluggish. We're big on our WOCLs in aviation. And it's between 3 and 6 in the morning, basically. It's when Alex and his short haul on the 320 are just starting their day's work. And it's when we on our long haul are finishing our day's work. So in other words, put it all together, you could have been awake for 20 hours and you're expected to plonk something down that's got 500 people on board, the most complex maneuver that we will do on our duty day, and you've done it when you're absolutely shattered and your body is in the worst possible state to carry out that complex maneuver. Now, we can't escape that in the same way that you can't escape. You've got your long duty days and it's been a nasty night in A&E or whatever. But so the question is, how do you mitigate against those factors? Because from what we've seen, people just assume just get on with it and just grit your teeth and get on with it. Well, that's, if I'm going to be controversial, I think that's unsafe. I think it's not recognizing a problem. The way we mitigate against that one is briefing, and we share that, and we'll basically say, okay, guys, I didn't sleep. My rest was appalling. I didn't get a wink sleep. So I am knackered. So, we've got to land this thing. Let's take things nice and simple. Let's keep it standard. Let's not accept any shortcuts from air traffic control. Let's let's keep all our communication standard, and crucially, let's watch each other's backs. So take it easy, slow the aeroplane up early, make sure that there was nothing startled, nothing that's actually going to be a potential, don't generate any trip hazards, and watch each other's back. But if you don't communicate that one, then you're actually putting another link in another slice of Swiss cheese with a hole in it. Whereas if you brief, you actually put that barrier in the place and stop the effort coming. So it's a recognition that we will not be perfect in operating at our best. And if we know that that is likely to be the case, brief it. Does that make sense?
That does. Thank you.
Thank you very much. That's very, very clear answer. If there is, Tandib, is that your hand, old hand or new hand?
It is an old hand, sorry.
Okay, thank you. So in that case, if there is no more questions, we really enjoyed the talk, Dave. I think everyone enjoyed it. It is really important for us to understand what's going on in other industry, which is very near to us in terms of safety. We are hoping to reach that safety level. But I think it is very appreciated your presence with us. It's really appreciated. We learn a lot, all of us. Thank you very much. I will now move to Mr. Gordon, who is going to just give us a brief talk about the scenario in terms of the management and the whole learning point from the medical point of view. Okay, it's all yours, Mr. Gordon.
Whoops, am I there? Thank you.
Yeah, you are live. Yeah, I can hear you.
Okay, we'll just get this on. As you can see, I'm not Rebecca.
Hold on, just bear with me.
So while we're getting that up, as you can see, I'm grey, but I still have all my hair and I haven't been to the hairdresser for a while, so I'm sorry about that. I'm an old-fashioned gynecologist, so PPHs really came into vogue probably 25 years ago when there was an increased risk of deaths associated with it, and people thought, yep, we need to get on and sort things out. And that's when the first proformas came in, which have changed a little bit with some of the new inventions, but much it's the same. It's the same scenario, that you have to have teamwork, you have to know what you're doing and get on with it and treat quickly and efficiently. And I think that's what these scenarios help to train people into. So it's just, why is it not moving? So PPH is defined as more than 500 mils. It's slightly irrelevant, but that's international definition. Primary PPH is before 24 hours, secondary PPH from 24 hours to 12 weeks, and that's changed over the years. It used to be 6 weeks, now it's 12 weeks. And the commonest cause for a secondary PPH would be infection. Usually, if we do it with people there, we'd be asking people questions, but it's difficult without seeing, so we're not going to do that if people don't mind. And worldwide, it's a major cause of mortality. UK incidence of massive obstetric hemorrhage, which is said to be more than 1.5, is about 1 in 270, although sometimes it seems that we have a few more than those going on, so we just need to be careful. So I think one of the keys is to try and prevent people coming into labour anemic, and to realise when people are on the labour ward, which is why it's important when you do your labour ward rounds, to actually go through the notes of the patient, not just, and make sure that we've picked up any risk factors for a PPH. So tone, what do we mean by tone? We mean is anything that's going to make the uterus not contract afterwards. So multiple pregnancy is the typical one. Previous PPH, so if you've had a previous PPH, you're 3.5 times more likely to have another PPH. If you've had a multiple pregnancy, you're 3 to 4 times more likely. If the baby's big, so a baby's bigger than 4.5 kg, you're more likely to have a PPH. If you have failure to progress, so if somebody, or we shouldn't say failure to progress, if you have delay in the second stage or in the third stage of labour, you're more likely to end up with a PPH. In the third stage, it's up to 7 times greater risk of PPH. And if you have a general anaesthetic for a cesarean section, it shouldn't be forgotten that that will potentially relax the uterus and cause you to be more likely to have a PPH. Tissue, so tissue is placenta, so retained placenta afterwards, or a placenta accreta or something similar to that can cause it. Trauma, and so trauma tends to be perineal trauma or episiotomy, okay, and they can bleed quite significantly, especially if you've got varices. And it's important to get on top of those quickly. And then thrombin, which is preeclampsia, and coagulopathies, which occur once you've got into that cycle of a massive PPH. The important thing is to identify high-risk women, and now we've got, in every set of notes, we've got lots of pro formas that we're expected to fill in. They sometimes get filled in well and sometimes they don't, and when they don't, that's when the women come into labour with haemoglobins of 8, and I'm sure we've all seen that. And when you look back at the notes, you can see that their booking haemoglobin was less than 11. So if your booking haemoglobin is less than 11, that needs to be investigated. It's not normal. And if your 28-week bloods are less than 10.5, again, that's not normal, and you need to investigate that and commence iron therapy. The problem then sometimes occurs, you've diagnosed it, you've started them on therapy, and nobody does anything about it. And as anyone who's taken iron knows, it can upset your stomach. So a lot of women don't take it. And unless you ask, you won't find out. And sometimes you ask and patients want to say, yes, I've taken it, doctor, because they want to please you. So they say yes, nobody repeats their haemoglobin, and they remain anemic, and they have a very low haemoglobin when they come in. So if you diagnose it, you have to check the iron's working. So you need to check their iron. The iron will come up if you're on appropriate dosage, 1 gram a week. So it's probably worth checking it a couple of weeks later to make sure it's coming up, especially early on in pregnancy, because then if they're not responding, you can give them parenteral iron. Diagnosing, in the old days, it used to be said we didn't measure properly and people guesstimated. I think now that we have people are measuring and taking the swabs and weighing them, we're a lot better at deciding how much the blood loss is. Occasionally, some of us are feeling we sometimes overestimate it, and somebody's had a massive blood loss, and then they're given some blood, and their haemoglobin comes back and it's above 10. And you kind of think, did we overestimate it? So that's something I think we do need to be careful of, but it's better to overestimate it than underestimate it. And then when you're treating the PPH, as has been seen in the scenarios, a checklist can be useful. I would like to say in the old days, it was written down on a, when people were acting as scribes, it was often written down on a piece of toilet paper or something equally daft, a scrappy piece of paper that then got lost somewhere and never put in the notes. We now have something in the notes, but unfortunately my experience, and I think a lot of people's experiences when they review things or just going through the normal notes when nothing's gone wrong, is these don't get filled in. So it's very good that we're doing all these things and we've got these pro formas to fill in, but unless we actually fill them in and take some note of it, what people tend to do is write in the rest of the notes. So I think we need to get a culture where there is a PPH and we go straight, because it's in the notes, we go straight to the notes and start writing in the appropriate pro forma. I wonder if anyone's got any views on that at the moment. I can't see if any hands are up, but...
Okay. Anyone had any question? If you have any question.
No, I'm not finished yet. No, I haven't finished yet. I just want to know if anyone's got any opinion on what we've said so far. No? No question. Okay. So one thing you also need to realise, there's some things that are good at reducing blood loss at normal deliveries and some things that aren't very good. So uterine massage prior to any PPH is of no benefit whatsoever. You hear people say, oh, we'll massage up the uterus, make sure she doesn't. It doesn't work. There's been 2 clinical trials that show massaging the uterus doesn't work. Prophylactic uterotonics do work, so they should be offered. Okay, so that's the standard that we offer all women. And again, if they're at higher risk, then we offer a little bit more, which tends to be IV syntocin infusion plus or minus misoprostol. The college guidance is multiple is probably better than giving a one-off, but it's not evidence-based, but it probably makes sense. So if you've got somebody who's a very high risk, so somebody with a multiple pregnancy, fibroids and a cesarean section, it's probably worth giving the Synto and the misoprostol. Okay. Tranexamic acid is the kind of thing of vogue at the moment, and everybody seems to be getting it. The trials actually showed it's beneficial was actually a few hours later, when people were bleeding a few hours later rather than immediately at the time. So it's difficult to know whether it's always of benefit, but people are kind of using it a bit like they used to use brace sutures. When brace sutures came into vogue, every other person that had a cesarean section seemed to have a brace suture. And I think sometimes just waiting a little bit and massaging the uterus at cesarean section can help, and waiting for the uterotonics that you've given will settle things down. But I think tranexamic acid is a very easy thing to give, and it has very few side effects. So it's something we should be thinking about. So this is the pro forma that we need to fill in. I must say, I rarely see it filled in. I've been on labour ward twice this week, and I have been looking through the notes, and these don't seem to be being filled in. So I think it's something that we need to do, because you know, asking in every room, what's this lady's hemoglobin? Oh, it's been taken, we're not sure. You know, people should know. It should be part of the pro forma when you're handing over the SBAR. This lady's hemoglobin is X, Y, and Z, and we should rule out any of these things as part of the. I know it happens in some cases, but often it gets forgotten about. People just assume everything's okay. So the key is we must be filling these in and talking about them and using them appropriately. Stage 1 is PPH. This is when we need to start using the pro forma. What usually happens, and I'm guilty because we had a PPH, or it wasn't really a PPH, we had the emergency bell went off on Wednesday, whichever day I was on. We went straight into the room. She had delivered, a lady had delivered, she had had prolonged rupture of membrane, so she was at increased risk. She had had 2 previous deliveries, and we'd already planned, because she'd had PPHs previously, we'd already planned that we were going to give her Synto infusion and some misoprostol afterwards. Placenta came away as soon as the baby was delivered, and she had a bit of a gush, which was probably 500 to 600 mils, and then she settled. The first thing I do when I go into the room, I don't know about other people, is you introduce yourself, and then you go straight to the patient. I put my hand straight on the patient's tummy and say, this might be a little bit uncomfortable, and then carry on chatting and getting the handover. I think that's very useful because it doesn't waste time, and then you can start taking stock of what's going on. And in her case, everything had stopped, so we could go out, and I didn't fill in the form, so I'm as guilty as anyone else because everything had settled itself down. But it is important that we do fill these forms in, because if we get used to it, I think we'll be better at managing PPHs and better at estimating blood loss. If it's ongoing PPH, more than 1,000, again, it's another pro forma that we can be using. We can review the prophylactics we're giving and write those down. Again, they're usually written down on pieces of paper or in the notes on another piece of paper. Bimanual compression is useful when you've actually got an ongoing PPH while you're waiting for the other things to work. So I'm not saying it's not of use, but beforehand, you can't rub up a contraction when somebody's had a normal delivery and expect that to prevent a PPH, because we know that doesn't work. But when you've got one going, it can be helpful, and while you're waiting for the uterotonics to start working. Okay, it's important, as has been seen in the scenario, you know, empty the bladder, make sure it's draining, inspect the genital tract, repair genital tract, any trauma, check the placenta and membranes, which sometimes can be quite difficult. And then if it's more than 1,500 or it's 1,000 and ongoing, or there's clinical concern, then you call your massive obstetric hemorrhage. Okay, and you order your blood, you get the 2 lines in and everything we've done there. But again, document who's done it, who's been there, and what's been going on. I know we're speeding through this because it's tea time and you're all a bit bored. But I think it is important that we do start using these forms rather than pieces of paper, because it makes it a lot easier when we're reviewing cases to see whether we're performing appropriately, because sometimes we are, but we just can't tell, or if we're not, and whether we need to improve our scenarios and our simulation training, or have it more frequent until everybody's up to scratch on going through the performer in a logical sequence to prevent women ending up with massive PPHs. Because in the UK, unlike abroad, the majority of people with a massive PPH are going to survive. But if you survive with a hemoglobin of 7 and you're going home, you're going to feel pretty awful. Whereas if people got on top of that PPH earlier on and you have a reasonable hemoglobin, you don't require blood transfusion, you're a lot more able to look after your baby and enjoy your baby. So I think that's the important thing. But I think the most important thing from my point of view is prevent people going into labour being anemic. If we can do that, it would help a lot, because if your hemoglobin is less than 9, you've got an increased chance of a PPH, whatever kind of delivery you have. So again, having a low hemoglobin going into labour does increase your risk of PPH. Not only the fact you've got less reserve, you're more likely to bleed as well. We've got the uterotonics that you need to do that. And again, I can honestly say I've never seen this filled in, and I don't review that many notes, so those of you do. But again, it just doesn't seem to be done. I'm sure it's documented, but you know, if we're going to use pro formas, we need to use them appropriately. We see them in gynae clinics and various other clinics, and once again, people tend not to use them. I'm not sure why, but again, we need to get into the habit of using this, and it will remind people what we should be using so you don't forget. Although, you know, you can use a checklist to start going through it, but we need to make sure people have given it, and appropriately, and why. And again, you can see on the list, it says to remind people, because it has happened in the past that people have been given ergometrin when they're preeclamptic, and people unfortunately have come to harm. Not here that I'm aware of in the recent future, but elsewhere, and it has been reported. So again, it is vitally important that we do take the whole scenario and not just concentrate on the PPH. You need to look at the wider picture. There's always 2 units of O negative blood in the labour ward fridge. You can use cell salvage at some caesarean sections. People are using balloons, and again, venous suture, uterine artery ligation, balloon occlusion or embolization. That would more likely be used when you're expecting a large blood loss. So if you've got a placenta previa or a placenta accreta, our accretas all now go to Oxford. But sometimes you can get them and they've not been diagnosed. So again, people need to be aware that there are occasions where you might need your interventional radiologist to come along as an emergency and sometimes as a prophylactic measure, and very occasionally hysterectomy. The previous confidential inquiry where PPH became a major issue, which, as I say, was over 25 years ago, one of the issues they had was people were very slow to go to hysterectomy. So they waited and waited and waited. The patient was so moribund, and then they did their hysterectomy and the patient didn't survive. So again, if you have got a scenario where things aren't settling them down, they continue to bleed, and unfortunately hysterectomy is the only way to save the life, that's what you need to do. It's a good idea to speak to another consultant, get another viewpoint, see if you've missed anything and if they can come in. But again, all obstetricians should be able to do a hysterectomy as a life-saving procedure without having somebody else come in, I think. And then sometimes the postnatal care can be on the labour ward if you've got a dedicated space on labour ward and one-to-one nursing, or on an ICU. But again, it's having enough people to look after the patients and to remember, you know, they've had a PPH, they're more likely to get another PPH, ongoing PPH, and so they can bleed again. So it's important that they are regularly monitored. And again, after caesarean section, sometimes some observations are done, but unless you have a look at the pad and make sure that observation is done, sometimes the blanket's taken apart and there's a massive PPH, and then they realise why the patient's a bit tachycardic and beginning to look pale. The other thing that we've not mentioned and wasn't relevant to the scenario is, why do ethnic minority patients do so badly in the UK as compared to their Caucasians counterparts? What we all used to thought was it's because people came from that part of the world where they're more likely to have other diseases, hypertension, fibroids, etc., etc. But the evidence disputes that. It's not, in fact, the case. And I think one of the reasons we've had recently is sometimes we're not very good at picking up signs in people whose skin isn't white, that they're looking pale and looking pretty awful. So if you're an English rose and you lose 1.5 litres, you look pretty pale and ghostly white. If you're black or Asian, you might not, or you might have a slightly lesser, but we're not as used to picking that up, or we don't seem to be. And we had a case recently with a patient on the ward who was actually up and about and doing most things, she was reviewed 2 or 3 times by a registrar, but they didn't think she was that unwell, and her hemoglobin eventually came back as 5. And she had ruptured her uterus, having had a normal delivery from a VBAC. So again, we need to take more care of patients who you might miss the classical signs of pallor. You know, if you're tachycardic, blood pressure goes down, and often the blood pressure, as we've seen, doesn't go down until you've lost a fair bit of blood. We don't want to miss these cases, and we need to improve the health and well-being of BMA patients. And that's the college has got a working party on that, and will report, I think, next year. But I think that will be one of the things that we need to think about. Are there other symptoms and signs that we can look for, or learning protocols? There might be photographs that they bring out. I don't know what they're going to do to try and improve our assessment just by looking at patients. PPA post-event checklist. Again, people aren't filling these in because I think people are so relieved everything's okay and the patient's okay and everything's settled itself down. We're all busy, but I think if we write on these rather than write in the notes, because people are documenting, but it's this, they're not documenting on what we've decided now as a trust that we should be documenting on. So I think that's the important thing. Let's try and document in the appropriate place. It makes it a lot easier to see if we're doing well. And if we're not, it means we can put actions into place to try and improve our managements. Okay, we've run through that quickly because we're 5 minutes into tea time, so I'm sorry about that. But is there anything anyone wants to ask particularly?
Thank you very much, Mr. Gordon. That's very comprehensive talk about a very important subject. PPH is our daily bread and butter, and it is the most common cause of death worldwide. It's not in the UK, I know that, but it is a very important subject. And we all think sometimes we know a lot of things, but there are a lot of things sometimes we don't do it in the correct way. It's very good that we revise ourselves of this. Please, any question? If anyone had any question to Mr. Gordon about anything, so raise hand, and we wait for 1 minute. If there is no answer question, then you all go for coffee break, and we'll come back at 4:15 so that we can finish the day on time. Okay, it looks like your lecture was very comprehensive, Mr. Gordon. Thank you very much. Okay, so let's go for a coffee break, and we will come back at 4:15. Thank you. Sorry, a bit rushed, but that's good. Is that okay? I didn't see it. No one have any. Where is any?
Okay, can you hear me now? Can you hear me now? Yeah.
Yes, we can hear you.
Great. Okay, thank you very much. Thank you. I can't see anything to turn off my mute or anything. I can't mute myself. There. Okay. Perfect. Then I can use this over here if you want. We're starting at 1:15. It is 1:15 now. Should we? You let me know when to start.
Okay, are we all back? We can start now. Emily Robson is here.
Okay, great. I'll take my mask off. Okay, lovely. Can you hear me okay? Brilliant. All right, so this is a short recap of maternal sepsis, and our key learning points for this talk are being able to recognise maternal sepsis and the importance of using the MEOWS chart properly. Also, the importance of senior multi-professional involvement early with sepsis, the use of serum lactates to diagnose sepsis and track its severity, the need for early intravenous antibiotics and fluids, and knowledge about the sepsis 6. So a little bit of a scenario, just to give it kind of a real patient perspective. You're working on the postnatal ward and take routine observations on Mary, who had a normal vaginal birth yesterday, baby George. And Mary is normally a fit and well young woman, and she now has 3 children. Her other children are aged 4 and 2 years old. So what we've got here is Mary's MEOWS chart. Now, what I'd really like is for one of the midwives to take us through this MEOWS chart and just tell us what they can see and what that means. Is anyone happy to take on that job?
I will.
Brilliant, thank you. Sorry, I can't see
It's
you, but
Claire.
please. Hi Claire, please talk us through Mary's MEOWS chart.
Okay, so she has had several sets of observations taken over the course of the same day. So it's the 17th. I can't quite see the date, but it looks like it's the same day. So 4 o'clock, so at 4 o'clock, the observations I would say are normal. She has no scores in the yellow or the sort of orangey red boxes, so that's been considered to be normal, and the person's filled in the form at the bottom with 0, which is correct if everything falls in the white boxes.
Yeah.
So the second set of observations also has been scored as 0 again, and then in the third set of boxes you can see that there are some observations that are outside the normal range. So the normal range is in the white box. So it's she's got an abnormal heart rate, abnormal temperature. I can't see the blood pressure. The systolic blood pressure isn't recorded on that. I can't see. No urine output, and she's scoring. Well, they've written 3 and 4.
Okay, so
they've called a doctor.
So 3 for the total amber scores,
Yeah.
and 4 for the total red scores. So I'm not sure if you can see it quite as clearly as me, but I can see that the top one is the respiration rate is 28, and that's an amber.
Mm-hmm.
And then, as you said, the urine has been charted as an amber. And there's one other amber somewhere.
Oh, it's the heart rate. No, sorry, the heart rate's kind of on the cusp, isn't it? So the other amber is it is the heart rate. Yeah.
And then no, actually, no, it's not. It's right at the bottom. You see where it says looks unwell. Okay. No and yes. There's a tick in the amber there for looks unwell. Yes.
Yeah. Okay.
Do you see what I mean?
Yeah.
And then if we go through the reds, she gets a red for the saturations, 94% on air. She gets the red for her temperature, which is 39. And then I think you said you couldn't see it very clearly, but actually the systolic blood pressure is 65, which is
now
a
that
red.
I've zoomed in, I can see that. Yeah. So so yeah.
Yeah. So as you say, 4 reds. And do you know? So she's got 4 reds and 3 ambers. So what do we do when we get that kind of score?
So she needs it needs to be escalated to somebody more senior, so a doctor.
Yeah. So if you turn over that meows chart, it has a few it basically tells you what to do on the back of the chart. And the most kind of severe, it goes from white to 1 yellow to 2 yellows or 1 red to 2 reds, and the most severe end is more than 2 reds. And obviously this woman would come under that, wouldn't she? She's got 4 reds. So it says on the back, if you have more than 2 reds, to get the midwife coordinator to assess immediately, for an obstetric registrar to do an urgent review, and for either them or someone to discuss with the consultant obstetrician. And then do you know what about observations? How frequently do we need to be doing observations if we've got 2 reds or more?
I want to say 15 minutes probably.
You're absolutely right. Every 15 minutes or more, it says. And you can actually, with the 2 or more reds, you would consider putting out a 222 obstetric emergency to get the resus team. Now, tell me, it says, what is the likely cause? What are you thinking is the diagnosis? What's going on here?
Sorry, I can't remember the previous slide.
Wow, so it's a woman who's on the postnatal ward. She's, I think, about 24 hours post a normal vaginal delivery. She's had baby George, and she's normally fit and well, and she has 2 other children. She has 3 children now.
So I'd say, looking at the fact that she's got a raised heart rate and temperature, it's probably an infection. That's what I would imagine. That's what I would be thinking.
Absolutely. So thinking sepsis. Yeah, that's great. Thank you very, very much, Claire. Thank you. So we would be thinking sepsis here. And this next slide is the 2020 Embrace report for 2016 to 18. So Embrace stands for Mothers and Babies, Reducing Risk Through Audits and Confidential Inquiries Across the UK. So in this latest report, the rate of death in pregnant women was 9.7 deaths per 100,000 pregnancies. And of these women, in this 3-year period, 217 women, or in total, 217 women died. And of those women, 23 died from sepsis. So sepsis is very much something that is still killing women in this country, in the UK. And there's some new recommendations from this report that have come out of the cases that have been reviewed, and there are also some existing recommendations that require better implementation, it was felt. So the new recommendations on sepsis are for preterm, pre-labour rupture of membranes, what we call PPROM. And what has been recommended here for PPROM is for early senior involvement and full explanation of risks and benefits on whether to continuing the pregnancy, and to risk assess and counsel appropriately. Now, I'd like to ask one of the obstetricians in the audience, would you be able to enlighten us a bit further what that looks like, this risk assessment and counselling a woman with preterm, pre-labour rupture of membranes? Does anyone want to volunteer themselves? Please. Do we not have any obstetricians? What about one of the midwives? Please, can you see hands up? And can you see hands up? No hands up. Okay. How would you counsel a woman with PPROM about risks and benefits of continuing the pregnancy?
Go, Claire, go talk.
You're going to know more than me, so, you know, don't worry.
Oh, what? Sorry, sorry. Did you think I was going to talk? I'm quite.
Yes, I said you can talk.
Oh, okay. I wasn't actually gesturing, but that's okay. So I guess, I mean, it's a balance. We're asking about counselling in relation to providing treatment for them. It's a balance, isn't it? She's going to become quite unwell if you don't treat her. With potentially ending the pregnancy, and she would need some input from the neonatal team as well, I'd gather. So it would need to be kind of an MDT thing, I think.
Yeah. Yeah. Okay. Thank you. Thank you. The next slide is about, as I said, existing recommendations requiring better implementation. So this talks about the flu vaccine for pregnant women. It stresses how important it is to provide an interpreter, and it says that, you know, we shouldn't be using women's families for this purpose. Something that I think we do quite a lot at Wexham Park. So something really we should be thinking about a bit more, I think. Really checking a woman's understanding, and then to think sepsis at an early stage. So the key messages on sepsis are for rapid diagnosis, prompt senior involvement, and appropriate and timely sepsis management. And this will involve using language line where needed, involving the midwife coordinator early, the consultant obstetrician early, the anaesthetist on labour wards, and then also the microbiologist, the outreach team that we have 24/7, and ITU. Okay. And then things that should make you think sepsis include, as we've said already, the preterm pre-labour rupture of membranes. So influenza and COVID, obviously. If someone's had a cervical suture, and then abruption, an IUD with pyrexia and tachycardia and a low blood pressure. Mastitis, we see pretty commonly, was a woman on the labour ward yesterday. And then anyone postnatally who's unwell, you want to do a full set of observations. So TPR, that's temperature, pulse, respirate, blood pressure, and consider her condition. The good thing about the MEOWS chart is it's all there. All the observations you need are there on one chart, and it tells you how to assess the severity of all your observations. So really, you know, it is a great tool to use for sepsis. And then obviously there are non-obstetric causes of infection. So other bits of the body, so a chest infection, have they got a cough? Do they need a chest x-ray? Do they have a urinary tract infection? You could get a septic focus anywhere, really. So really just to think about other sources. BAME is there. So I think sepsis is probably slightly more prevalent in the ethnic minorities. And again, they found in the inquiry that communication difficulties are associated with cases of sepsis. And as we know, obesity, diabetes, and decreased immunity all put you at higher risk for sepsis. So sepsis recognition, we've kind of touched on it already. So early and regular clinical observations, pulse, temperature, respiratory rate, SATs, blood pressure. If you're worried about a woman, she doesn't look quite right, you do the meows chart. One other thing that's mentioned there is the shock index. So this is heart rate over systolic blood pressure, and it is a score used to detect early hemorrhagic shock and early sepsis. And a normal range for shock index is 0.5 to 0.7, and anything above 0.7 is abnormal. So as we've said, plot the observations on the meows chart and act on it. Turn it over and on the chart and see what you're supposed to do. So here it says 1 red or 2 amber. So if you look on the back of the chart, if you've got 1 red or 2 amber, what you're supposed to do is you're supposed to get an obstetric registrar to review the patient within 30 minutes, and you're supposed to do your observations every 15 minutes. And it says here that reduced or altered consciousness, it basically is a very late sign of sepsis. Someone is very severely unwell if they have a reduced or altered conscious level. So symptoms of sepsis, they're very diverse, and this is why with so many various different symptoms, you kind of have to think sepsis with basically everything. So diarrhea, vomiting, abdominal pain, rash, a sore throat, green sputum, offensive smelling vaginal discharge, a wound infection. Always take the dressings off and have a look at the wound. Pain passing urine, and a low urine output. It says here less than 0.5 mils per kilogram per hour. And if you work that out for a 60 kilogram woman, that's less than 30 mils an hour, would be concerning. So, and signs of sepsis. So a raised respiratory rate over 22, or a woman looking like she's working with her breathing. A tachycardia, heart rate over 100. A high temperature, 38 or above. Not only a high temperature, but also a very low temperature can be a sign of very late premorbid sepsis, something below 35. Hypotension, low blood pressure, so a systolic blood pressure less than 90. Always look at a woman's normal booking blood pressure, just so you know how to interpret that systolic blood pressure. Low saturations, so less than 95% on air. Poor peripheral perfusion, so capillary refill more than 2 seconds. So to do the capillary refill, you can do it centrally on the sternum, or you can do it somewhere peripherally. You press for 5 seconds, you release, and then you count how many seconds it takes for the skin to go from white back to pink or its normal colour. And anything over 2 seconds is prolonged and a sign of sepsis. And confusion and agitation, as we said, is a very late sign, and rash or mottled skin. Group A streptococcus, or Group A strep, as it's known, is a leading cause of maternal death from infection in the United Kingdom. So this is a community-based infection. It affects many of us. We're asymptomatic carriers of it in our throat or our skin. And a streptococcal sore throat is a very common childhood infection. And if you think back to the scenario we had, our lady, Mary, I think she was called, she had 2 other children, 2 young children, and that's why that little bit of the, the vignette was included in the story. So yeah, risk factors for getting group A strep are working with or having young children. So always inquire about that. If you had a young child that's been unwell, had a sore throat recently. So women in the immediate postnatal period, like our lady, and also it's much more common in the winter. Now, this here is the inpatient maternal sepsis tool from the UK Sepsis Trust and what we use at Frimley Health. And to go on to this pathway, you need to answer yes to one of 3 questions. So the first question, has the meows triggered? So just triggering an amber on your meows is enough to start this sepsis pathway. Okay, so it's quite a low threshold for starting the pathway. And the other questions, if you answer yes to for starting the pathway, is does the woman look sick? Or is the baby tachycardic? So that's the baby with a heart rate over 160, you start this pathway. And if it's a yes to any of those 3 questions, you work through the sections. Now, if you have 1 red flag, you need to do the sepsis 6 pathway now. And if you have 1 amber flag, you do something that I hear a lot of on the labour ward. You do a partial septic screen. So a partial septic screen, I've learnt recently, is standard bloods, including a lactate, but no blood cultures. So you do your partial septic screen and you call for an ST3 doctor and the midwife coordinator. So that's an amber flag. If you have a red flag, you do the sepsis 6 pathway, which is on the back. Now, does somebody want to take us through the sepsis 6? Does someone want to do some talking instead of me? Please. No? You want to hear me? All right, so you can read it yourself. The best way to remember the sepsis 6 is that you give 3 things and you take away 3 things. So the 3 things you give are oxygen, high flow oxygen, IV antibiotics, and IV fluids. And the 3 things you take away are blood cultures, lactate, and the urine output. Okay, but it's all on there for you. So rapid IV antibiotics are very important. High dose, broad spectrum IV antibiotics should be given as soon as possible. But yeah, and this should not be delayed for the results of your micro testing. Okay, and if possible, you take your blood cultures before the antibiotics, but you don't want to delay giving your antibiotics. A microbiologist should be contacted early for advice. And if someone is extremely ill, deteriorates or doesn't improve, then you might want to give additional antibiotics such as gentamicin or clindamycin or tazocin. And this is just a graph of the odds ratio of death from sepsis increasing with delay in giving your IV antibiotics. It's a very, very clear increase in odds ratio of death if you delay your antibiotics. Fluid resuscitation. So low blood pressure and a high lactate. So your level for lactate is 2. If your lactate is above 2, then you're concerned. So low blood pressure and high lactate should be treated with IV fluid boluses. And so it's recommended to give 500 mils of plasmolite over 15 minutes. And you can repeat that up to 2 litres for a normal sized woman. Okay, and if there's no improvement in your blood pressure or no improvement in your lactate levels, then this is when you contact intensive care and outreach to get involved. And just to be aware, intensive care treatment of a woman who's sick like this needs to start wherever the patient is located. If the bed is going to take 3 hours to be free in the intensive care unit, you need to start the intensive care treatment at the woman's bedside where she is at the moment. And don't wait 3 hours before starting. So, to summarise, be aware of sepsis and beware sepsis. If sepsis is considered in the community, refer the woman into hospital urgently. And to just be aware that the onset of life-threatening sepsis can be insidious and subtle. And there can be extremely rapid changes very quickly. The sepsis 6 needs to be done within an hour, so you really have to get on with things. Early liaison with microbiology and intensive care where appropriate, and to use lactate to diagnose and direct the management of sepsis. Are there any questions?
Okay, if there's any question, just raise hand, please. Okay. Or is it thank you very much, Emily. That's a very thorough talk about sepsis, which is, as Emily said, it's very important subject in maternity, and it is always coming in the report, and still we have ladies and patients die from it. If everything is clear, then we are going to move to our last lecture, which is going to be done by Dr. Nimisha Patel. Thank you very much, Emily. And yeah, Nimi, are you online?
I am.
Okay. It's yours.
Trying to share my screen. How do I get onto my desktop? Sorry, I'm just trying to work out how to get my... Does Zoe have my presentation there? Zoe?
Yeah, I'm just going to see. But need the presentation of Nimisha at the bottom.
I'm not quite sure how to share my screen. Give me 2 seconds.
So yeah, while we are waiting for the presentation, can I just remind everyone to fill the feedback form, please, because that's very important for us to see if we can improve on anything. So the feedback form, as Zoe mentioned to you, it is just like you take it from that bar that she gave it to you and just send it back to us, please. Yeah, I can see always we have to ask our kids. Yeah, very good. Thank you. Yeah, I can see. Just go to show slideshow so you can this big screen.
Sorry, I just try to. Yeah, got it. Okay. So. Okay.
That's fine. Oh, brilliant. Yeah, I can see. I can hear. Thanks.
Brilliant. Okay, right. Sorry about that. So I'm going to try and give you a brief run through maternal critical care and COVID-19 in maternity. So what is critical care? It is, as hopefully you all know, it's a specialised care required when somebody is has life-threatening illness, or when they require organ support, or when they need some advanced monitoring, such as invasive blood pressure monitoring. We are seeing more and more unwell women, and the reason for that was multifactorial. They're getting older, their BMIs are getting higher, and we're seeing a lot of women with other comorbidities as their age is higher, and also they're getting pregnant, whereas previously they wouldn't have. Where should we be looking after these women? So Emily alluded to this a bit earlier. The care of these women that are critically unwell should just start as soon as we recognise it, obviously. But in terms of ongoing location, obviously it'll be site specific. But for example, at Wexham, we have an intensive care stroke HDU facility. On the labour ward, we do have 2 rooms that we do locate us slightly more unwell women in. However, these are not areas where we want to look after these women on for many hours if possible. If they require invasive monitoring, then they need to be on the main intensive care unit. As an interim measure, we've also got recovery or PACU, where we can kind of provide this sort of monitoring if necessary in the short term. So what causes these sorts of conditions? So again, very multifactorial. There's lots and lots, and this is by no means an exhaustive list. But in terms of classification, if you go through respiratory causes, and the most common ones would be chest infections, moving on to something like pulmonary edema, which might be associated with your preeclampsia or a cardiac condition. Asthma, which is a more common disease in our pregnant women, and then bronchospasm associated with that, or with something like anaphylaxis. PE is one of the most common causes of death, direct death in our maternity population. Despite everything that we do to reduce it, it is still very much in existence. In terms of cardiovascular diseases, so uncontrolled high blood pressure, cardiomyopathy. Now, a lot of our patients particularly with sort of moderate to severe, we would be transferring out, but certainly if they come in an emergency situation, we may be managing them. Massive hemorrhage, we heard the talk about that and had the scenario, so very, very common, and probably our most common reason for admitting to intensive care currently. PE, septic shock, we've obviously talked about, and then sepsis. In terms of neurological issues, status epilepticus, we have, and then sort of epilepsy related to preeclampsia or eclampsia. We did have one lady recently with this issue. Meningitis, intracerebral bleeds, malignancy, and something sort of rarer like Guillain-Barré. So these are all obviously a lot rarer. So we've talked a bit about the MEOWS chart, so I won't sort of go into too much detail, but essentially this is an objective way of us calling for help. Sort of the healthcare workers or midwives, nurses on the ward, it's a very structured way of kind of calling for help. And the idea is to use your S-bar along with this in order to trigger. This chart, and unfortunately I did actually get hold of the one that we use at Wexham, but didn't manage to upload it. Essentially, our outreach team use a very nice structured review of patients, which looks fairly similar to this. It's very much an A to, whatever letter A to E approach, but this goes down into the P's, Q's, R's, S. But essentially, it's a way of putting together a structured analysis of a patient, whereby A is for airway, B is for breathing, obviously, and then sort of going into detail with each one. So what's their respiratory rate, what's their SATs, what their chest examination findings. And essentially, if you are on the ward with a sick woman, if you can put together a very basic version of this, it would certainly help in the referral, and it would help to kind of have an overall summary of what's going on in terms of the woman's critical illness. So a good sort of way to kind of go through their kind of physiology and what's going on with it. So fluid balance. very, very, very important when it comes to a critically unwell woman. And the number of times I've been doing ward rounds, and we found that women haven't had these filled in at all, or it's filled in but not not complete or inaccurate. So very important, and essentially it goes through what you're giving a patient and what's coming out, and whether there is a discrepancy there and whether that discrepancy is causing issues, and it must be escalated if there is a concern. So in terms of actually transferring women to the ITU, it should be obviously a multi-professional decision. It would usually involve the outreach team, which would generally consist of 1 or 2 nurses and an intensive care doctor. The idea is that everyone involved has kind of communicated with each other, and everything's done smoothly, including things like documentation and transfer of notes, etc. There's a note there about just as the patient is sometimes on the intensive care unit for many days, sometimes weeks. It's important that if a lady is postnatal, that they do have some sort of bonding with their baby, in terms of even if it's just photos. And I do know they have, partners and babies have been brought to the unit on occasion. So it is important in terms of bonding for that to happen. Do remember that, as I said, this is a multidisciplinary approach, and there are various people in the team that should very much be involved. And I think those are obvious, and I've listed them there. And yeah, it's essentially important for everybody to get involved. There are obviously long-term impacts for these women and their families. And it's important that we recognise this. So anyone who has spent some time on the intensive care unit, they do have sort of vivid memories. They may be having nightmares or hallucinations. Certainly I've seen a couple of women in our clinic who have spent some time there, and they've had strange recall of events. So it's important to then go back to these women and go and debrief them essentially, and really go into detail about what happened, because some of them will have a lot of questions, and then receive the appropriate support in terms of well-being. So moving on to COVID and pregnancy. So in the general sort of population, in pregnant women, it doesn't appear to be a very high risk. It manifests in the usual way, in one of 2 main ways, asymptomatically, i.e. no symptoms. We don't know the actual percentage of that, or it can be in this sort of acute, mild or moderate illness where you could get a fever. I'm sure you all know this list of symptoms off by heart: dry cough, loss of smell or taste, things just generalized sort of fatigue, headache, shortness of breath, and then your non-specific symptoms like myalgia, malaise, anorexia, headache, diarrhea and vomiting. So the third kind of type of symptoms are where it does then become it can turn into a critical illness. So around 20% of our pregnant women, symptomatic pregnant women, will progress onto severe illness, and only 5% of that overall will require critical care. And within that, there are 2 sort of lung phenotypes, if you like. So the first one would be where you just get the hypoxemia, where the lungs remain compliant, i.e. they still maintain their elasticity, and they're able to, the lady's able to kind of expand her lungs appropriately. They wouldn't necessarily have that sense of dyspnea, even with the low SATs. They may require oxygen. And then you've got your other sort of end of the spectrum, where you've got the ARDS, acute respiratory distress syndrome, where they do have compliant lungs or stiff lungs, and amongst that they're going to potentially require oxygen, CPAP or full-blown ventilation. In terms of other organs affected, so kidneys, where they may need renal replacement therapy, and that's up to 25% of those who are on intensive care. Cardiac dysfunction, so it could be an arrhythmia, it could be as extreme as getting cardiac failure, and then you've got your sort of your DVTs, PEs, which are already common in that population and become even more common when these women get COVID. So something very much to look out for and take prophylaxis for if you get a woman who has got COVID on the ward. So risk factors. So only 0.5% of our pregnant women need admission for COVID-19. And so it's obviously very low, and generally pregnant women do very well with COVID. Most of these admissions have occurred, so the data we've got has been collected over the last year, and essentially shows that only 0.5% of these women have been admitted, and that occurs during the 3rd trimester. Of the risk factors that they found, BAME, so our ethnic minorities, if they've got a high BMI, if they've got pre-existing comorbidities, and any mothers who are over the age of 35. BAME women are 5 times more likely to need admission, and one of the reasons that they found for this is potentially due to vitamin D deficiency. Okay, so how do we diagnose this? So very similar to our normal population or non-pregnant women, it can either be via PCR, or we can do the rapid tests that have become more widely available. Other tests which are not specific for COVID, but we can obviously do, are chest x-rays and CT scans, which I'll show you on the next slide. A low lymphocyte count, again suggestive but not diagnostic. A raised LDH, raised D dimers. A procalcitonin isn't necessarily specific for viral illness, but if you've got a raised procalcitonin, it can indicate bacterial infection. Procalcitonin is usually normal in a viral infection. And then raised CRP, again, very much not a specific indicator, but may well be raised. And it's good in terms of following trends. So chest x-rays, that they can show a bilateral peripheral lung shadowing, usually in the lower zones, and that's chest x-ray there is fairly typical of what you might see. On the right side is a CT scan of someone's chest with COVID. Appears typical, so typically fibrosed, and you get this kind of crazy paving type appearance. How do we manage these? So what we're aiming for is SATs of between 94 and 96. We would need to observe their and record their respiratory rate and SATs hourly, and obviously more frequently if that is deteriorating. And then obviously put them on oxygen or go down the route of CPAP if required, etc. Consider P if they're requiring a lot of oxygen, something very much to keep in mind. Cardiac damage causing arrhythmias and cardiac dysfunction. So we, in terms of monitoring them, we want to do an ECG and potentially an echo and check their troponin. Renal damage, so we would want to check their Usinase daily, at least daily, and obviously if it's deteriorating you might want to do it more frequently, and what we want to do is really avoid overfilling or underfilling these, so it's really important to do a fluid balance in these women. As we've already mentioned, the thromboses are very common, and we need to make sure that we're giving these women appropriate prophylaxis according to their weight. And this could be for a minimum of 10 days or up to sort of 6 weeks or even longer, depending on what's been going on. Okay, in terms of specific therapies, so steroids should definitely be considered if the patient requires oxygen, and for our pregnant women, unlike our non-pregnant women, it should be prednisolone or hydrocortisone. We use dexamethasone in our non-pregnant population. You can consider antivirals if the oxygen is required. However, the risk versus benefit of giving these sorts of drugs have to be weighed up. Antibiotics are not routinely recommended unless you suspect a bacterial infection as well. And as our previous talk showed, there are obviously many sources, alternative sources of infection as well, which must be ruled out. In terms of the baby, obviously this baby needs to be monitored if the mother's becoming unwell, if her saturations are dropping and she's requiring oxygen. We need to be monitoring them on the CTG or the fetal heart rate on a regular basis, and based on the individual as well, depending on what stage of their pregnancy they're at. However, obviously the maternal well-being is paramount and of the most important. So if fetal distress occurs, what we have to do is really stabilize the mother first before we intervene and deliver that mother, as in any disease process. Steroids for fetal lung maturation and magnesium sulfate for neuroprotection should be considered as per usual if the lady is preterm. And then an individualized kind of MDT approach has to be used in terms of how we're going to deliver the woman safely. And as I've already mentioned, the priority of the well-being of the woman and the mum must be of the greatest importance. So what are the biomarkers of severe COVID disease? So a raised ferritin, if you've got a neutrophil to lymphocyte ratio of greater than 3, if patient's thrombocytopenic and the count is less than 50, you must obviously stop your aspirin and low molecular weight heparin if this occurs. If you've got a raised cardiac troponin, a raised BMP level, which is a cardiac protein which is released when there's cardiac disease going on. A raised prostcalcitonin may indicate bacterial co-infection. Signs of deterioration in COVID-19. So if your respirate is going up really high, over 30, if they're requiring a lot of oxygen, so greater than 40%, which equates to about 5 litres on a face mask, in order to maintain their SATs over 94. Obviously, if the woman's becoming drowsy or if their urine output's tailing off, which could suggest their kidneys are becoming affected, or that they're hypovolemic, becoming more septic, then we really do need to refer these women into ITU as early as possible. So Embrace produced an update in August of last year, and these are the key messages for maternal critical care. So we should use an MDT approach with these women, with daily obstetric review for all of these women, even if they're off the labour ward and they're on the intensive care unit. They must have obstetric input. You can consider antivirals and other specific therapy according to the research at the time. Obviously, this is a new disease process and there are new therapies coming out all the time. Warn women with COVID at the risk of deterioration, and prioritise communication with their partners. So this is what Embrace have highlighted as key messages. There's just some useful resources in terms of COVID in pregnancy. Thank you very much.
Thank you very much, Nimi. Thanks a lot. So this is the last lecture. If anyone had any question about anything during the day. In the meanwhile time, I think Zoe is going to
I will put the QR code now. So as I said in the chat, if you are on site, switch to 4G, because when you're on the NHS Wi-Fi, it will not allow you to go on the form. So let me just share my screen quickly. And then go to your camera. Where is it? Nicola, can you see? Oh, hold on. I will do it this way. Let me just open it this side. Yeah. So if you go with your phone on this code on your camera, and it will take you straight to the feedback form. Can you not see it? No?
No.
Okay.
Just wait for it to open to everything.
Okay. I thought I was really clever with this. Obviously not. Just bear with me.
Well, while we are uploading this, I just want to say thank you for everyone. I think you all were really interacting in the session. We made it really a good one. And at the same time, I would like to thank all my colleagues who helped in running the session. Nimisha Patel, Emily Robson, Mr. Gordon, and Dave, the pilot. It was all, and Zoe, of course. I'm not going to forget Zoe, who organized all these things. Thank you. Thank you for all those who attended. So all your names have it here. So all who had been logged in, I have a list of names. So you all be considered attending this meeting. So, and it will be given to the department, so we know who attend, who is not. Just like the feedback, it's going to be if Zoe will.
Can you click on the attachment that I've just sent in the chat? Were you able? Is anybody able to open it?
Not yet.
Not yet.
No,
Okay.
not yet.
Oh,
Not
it's
yet.
on now. If you go, it
Oh,
will
yeah.
be on. So if you
Yeah.
don't, if for a bit you don't type in the chat, because it goes up and up and up higher. Just
Yeah.
leave it for a minute for everyone to scan it. So go on your camera and scan
I've
the
got
code.
it.
Got it. Yeah.
So if
theatres
Monica
and-
got it, that's it. Everyone has to get it.
So theatres, please, as well. If you can take your phones, I can see you sitting nicely there. If you can give us your feedback. So go closer to the screen with your phone on your camera and scan the code. Marino?
Zoe, I can't do that because I'm actually doing the whole meeting on my phone because my
Okay,
laptop
don't
won't
worry, Nicola. Don't worry, my lovely. Don't worry.
work.
I can send you the link. It's
Yeah,
fine.
that's great.
It's just the theatres that we don't have the emails. So if you
Me
go to
too
the
as well.
chat,
I can't see the feedback form, I'm afraid.
were you able to scan the code, and then on top of your screen it will say open in Safari if you have an iPhone. I'm not sure if you have something else what it will say.
I'm working on
And then
my
you have to
Android
click on
phone.
it.
It's not an iPhone, sorry.
So thank you, everyone. Thank you for coming. Thank you for giving us your
I think
feedback.
you might be missing. Unfortunately, when you put the image up, it's trimmed some of the targeting boxes off the edge, so your phone won't recognise it as a QR code.
Oh, some people were able to do it, so I'm sure it's working.
I've already done it, so it's.
Yes, it is working.
Yeah, it's fine.
Okay.
Thank you, Zoe. Bye.
Thank you, everyone. Bye.
Thank you, everyone.
Bye.
Thank you.
Bye.
Thank you very much.
Thanks, team. Really good. Really good session. Thank you very much.
Bye, Zozo.
Bye.